advisor and a clinician with international experience across the UK, US, and Middle East. He has trained at the leading international institutions, including University of Cambridge, University of London, University College London, and University of Toronto and Boston University. He works at the intersection of clinical medicine, digital health, AI-enabled care models, and healthcare systems innovation, with a particular focus on how emerging technologies can be translated into safe, scalable, real-world clinical practice. Dr. Vijay regularly collaborates with clinicians, founders, and investors to bridge scientific innovation with the clinical utility, workflow integration, and commercial viability. Today, he will talk about AI for diagnostic, real-world integration. Dr. Nigel, the floor is yours.
Thank you very much, and thank you for inviting me to come and talk this year. And just must say that it was great to follow these great lectures before with the two previous speakers. So I'm going to be talking a little bit about AI for diagnostics. Dr. Bassam elegantly spoke a lot about diagnostics for his in pulmonary medicine, and quite accurately, he said that it's also applicable in many other diagnostic fields. And I'm going to talk a little bit about AI for diagnostics and how it really is integrated in real-world experiences. And I'm going to frame this a little bit about talking about electronic health records and moving through to AI. So the next thing we want to talk about is just generally this whole issue of AI. So even though these ChatGPT models and GPTs have been around for about 2 or 3 years, they have been around for even longer, but probably only around for 2 or 3 years in the public arena with the development of ChatGPT and the ability to use that more commonly. And so that's when the major population has really become attuned to using it. But let me tell you something very clearly about the AI area and the world of AI. Just looking at this picture, the amount that we know about AI and where we are is only just the veritable tip of the iceberg. I mean, there is a huge amount that we will be learning, and we are learning so rapidly that sometimes a lecture like this will be out of date within days. Absolutely. So that's one thing to remember whenever you hear something about AI. It's moving so extremely rapidly that sometimes we can't even really grab what's really going on. And that is part of the problem. But to really talk a little bit about this, I wanted to talk about electronic health records, because you in the audience may remember that around 2009 or just before that, we as medical practitioners and doctors were deluged with electronic health records and the development of EHRs. And there were a huge number of promises made that this would make doctors' lives simpler, easier, it would be better for patients, everything would be better. But despite that, and despite the implementation of electronic health records, which, by the way, cost a huge amount of money. In fact, in 2009, when the US put their HITECH Act in place, the spend in the USA alone was between 25 and 36 billion US dollars. Okay, not as much as Elon Musk is worth, but certainly a fair amount of money. $36 billion. And when the EHRs were thrust as such upon doctors, there were lots of false prophets and people telling us that it would work. They told us that it would offer cognitive support, it would be a safety net, it would reduce administrative load, it would lead to earlier diagnosis, we would have more time with patients. We knew that it was going to be expensive, it was costly, it was vendor power, But there were many problems when it did get implemented. First of all, there was huge amount of physician burnout and alert fatigue, and there was also huge amount of underused functionality in these EHRs, insofar as when they came with all their developments, most clinicians only used about 5 or 10% of the open quote functionality of these systems. And sometime after that, Harvey Feinberg, who was part of the Institute of Medicine and Institute of Quality in the USA, said a really interesting thing. He said that we realized that these EHRs were not really getting us to where we were. And he said that a sustainable healthcare system should really be an affordable, adaptable, and acceptable healthcare system. And a successful healthcare system should offer superior care and fairness and lead to healthy people. And these things were things that, even though we spent a huge amount of money on, did not seem to improve significantly our healthcare delivery. So let's take that EHR, that story, as a warning, because over the last few years, we've had, again, huge number of promises made from AI that it will transform medicine and it will make everyone's lives better. We will free the world. We will save the children. Or is it save the children and free the world? I'm not quite sure. But basically, it's going to be the panacea. It's going to be something that's going to make doctors happy. It's going to make patients happy. It's going to satisfy what Harvey Feinberg suggested. But it is possible that digital transformation can make medicine worse before it is better. While the EHR digitized the record, it did not always redesign the work and the workflows. For EHRs often made doctors work for the machine. And we have to be really careful that in this new iteration with AI, that AI must make the machine work for the doctors. We know that medicine, year by year, becomes increasingly data rich. It is time poor, and many healthcare workers, physicians, nurses, and other healthcare workers are so cognitively overloaded that in a way they do need some kind of assistant to kind of sort the wheat from the chaff, because there's so much data. We're not talking about gigabytes, we're talking about petabytes or exabytes of data, and it's impossible for any single physician or even team of physicians to really understand and assimilate all this data together.
Again,
so
an important thing, difference between the PTE and the prevent.
AI
PTE
is
can calculate
going to
from
probably
patients'
fill a
range of 40
position
to 79,
where it
while
is
prevent
more an
is 30 to
assistant
70.
or an aid to us rather than anything else. We do know that we have a huge amount of data, and we know that we have, as doctors and healthcare workers, a limited amount of time. And I think AI enters that gap between information abundance and human attention, so that it can process the time constraints and the huge amount of data, and then come up with a kind of judgment which can then be used in further interpretations by healthcare workers. We know that in these forms of diagnoses, AI is really very good. But as Dr. Bassam was saying earlier, the problem with AI currently is, the main problem is bias. And bias really comes, as Dr. Bassam was saying, from how the data sets have been fed. Let's take a simple example of the chest X-ray. So we have lots of AI systems that can read thousands of chest X-rays at a time. But recently, over the last few years, we've noticed that these chest X-ray reading devices and using AI-assisted tools have led to biases in the way that they pick up disease. In other words, for example, in African American people, they underdiagnose and patients with serious chest conditions, and they come up with a surprisingly high false negative rate when they're reading chest X-rays of African American people compared to Caucasians or Hispanic people in the United States. And this is not necessarily because the X-ray is not penetrating into the body. It's more that the AI is picking up little cues from the metadata that surrounds the chest X-ray. So, for example, the AI can pick up, was this an old machine that this was done on versus a brand new machine? It can also pick up, for example, whether it can tell very subtle things from a chest X-ray, such as the amount of body fat, and it can correlate that very cleverly with racial differences. And by doing that, it can then, together with biases in the training sets, for example, in the training sets for chest X-rays, there probably are less African American people involved, and because of that, its output leads to high false negative rates and poor diagnosis. So we can't always just trust the machine because of this bias. Of course, there are new techniques now in all of these diagnostic strategies to try to help with that. There's something called adversarial debiasing, which means that you kind of then nudge the AI away from those biases so that you kind of try to give it positive bias to try to perhaps overdiagnose in those segments of the population where it was not working very well. Now, the key thing, another key area which is really kind of important is this idea of where does AI position itself with regard to physician. I remember speaking to a radiologist in the UK a couple of years ago about some research that had been done on breast cancer and how identifying mammograms, AI and chest X-rays, AI was able to pick up such fine detail and diagnose breast cancers that it even came up with over 10 or 15 different subtypes of breast cancer purely based on X-ray and mammographic imaging. And when I told this breast radiologist in the UK, in London, about this, she said to me, it can't be better than a human. And we had a big argument, about this, on a school sports pitch, where she says it's never going to take over. And I think this really brings an important point to something that we have to think about. Even when we were talking about EHRs, we have to talk about physicians as sometimes some of them being early adopters, some people taking a little bit of time because they perhaps have a little bit of cynicism, and then there are some very late adopters. But many physicians are really quite fearful of what is the unknown. They, at that time, considered AI to be something that is unknown, and they were scared for their jobs. I mean, you can understand why. Another really interesting thing is we talk about detection or machines or AI being able to detect things beyond the scope of the human eye, to detect exquisitely tiny detail or detail that we can't even process as humans. And we say that that is not diagnosis. But that's not necessarily the case, because when we look at AI in diagnostics, many studies have been published now where they tried this little technique out. They, in one case, said, why don't we use AI and make a diagnosis, but we'll always keep the human in the loop, and we'll have the human doctor at the end looking at what the AI said and giving the final interpretation, the final rubber stamp. On the other hand, in another group, they just made the AI make the diagnosis and they used that. And they compared these two groups. Guess what they found? They found that the AI alone, without a human in the loop, was far better than when the human was in the loop. And the fact was that when the human doctor was in the loop after the AI, either because they were a little bit hacked off, or because of their own built-in biases, or because perhaps they relied on the AI, they slightly overcorrected or made misdiagnoses, whereas the AI was better than having the human in the loop. Now, Eric Topol, who has advised the NHS, in a huge document a few years ago on implementation of AI in the UK, also suggest that a human should be in the loop at some stage. But one really wonders whether, in a year or 2 or 5 years' time, whether the human in the loop is the final interpreter, or perhaps they're bringing their own biases, which are certainly more obscure than perhaps the biases that an AI might bring. Now, we might say that one thing that AI diagnostics does is it may bring 5 practical roles rather than just being one magic doctor. I mean, AI is able to detect, it's probably able to triage, it's able to help us quantify, it's able to help us summarize, and it's also able to suggest and actually make a diagnosis. And I think the key question is, how does that help what clinical decisions we make? And do we need necessarily a doctor in the loop, as I spoke about earlier? But I think one thing that AI diagnostics and using AI in medicine will definitely help with is it will be able to assimilate a huge amount of data from different things. Dr. Bassam earlier was speaking about how it can look at notes, the notes that we make, but it can also look at the labs, and it can look at imaging, and it can look at pathology, and it can look at technology or information or data from wearables that patients have. And it can process this huge amount of data that no human will be able to process and contextualize where a patient is. We know this because we know from AI interrogation of electronic health records that it can pick up tiny subtle patterns in longitudinal data in the AI. So it can pick up people with perhaps early diabetes just by looking at their glycated hemoglobin or insulin resistance over a 10-year period, or even other more subtle clues that might help us. And that's one thing where AI is definitely going to help us learn and interpret the data of a patient more accurately. But as I said earlier, we have to be careful, and for users of Claude and ChatGPT, we have to be wary of what's called plausible diagnostic confabulation. One of the words you really hear often used with AI is hallucination. But AI is not really hallucinating in the traditional meaning of that word. AI is really just offering what I would call a plausible argument, but perhaps a specious argument or a specious understanding or interpretation of the data. Because AI is very good, whether using GPT models, of producing a kind of very fluent, flowing, coherent story. And it's so good at doing that, and it's so good at communicating to the doctor, and the doctor themselves or the healthcare professional has so many biases that they may just take it at face and believe what it says. And because AI does sound confident and logical and well written, and this clinical plausibility, but as I'm trying to point out now, there may be issues. It may be ungrounded. It may have the biases because its data sets haven't been set up correctly. It may be non-reproducible, and ultimately it may be unsafe. And that's why so many companies are now trying to look at checks about using AI within healthcare, whether it's in diagnostics or in interpretation or in speaking to patients or with ambient AI. But sometimes they add another AI into the picture and they put another AI in the loop rather than just putting the final human in the loop. So there may be sets of AIs like criticizing themselves and interrogating data to make sure that they're coming up with the correct suppositions and interpretations. This sensation, what we should really demand is we should, rather than AI giving us fluent, easy flowing intelligence, we want from our AI systems in diagnosis, grounded intelligence. In medicine, sounding right is not good enough for us. We need the information to be grounded in real data. We need it to be validated. We need it to be reproducible. We need it to be auditable, and that's a very important thing. And it needs to be uncertain when uncertain. I'm sure that many of you have used ChatGPT models, and you can often find that it always likes to flatter the user, and it doesn't like to admit mistakes. Many GPT models don't like to admit their mistakes. You can put simple mathematical things in and calculations in, and it may come up with a number which looks right, but when you actually look at the number, it's incorrect, off by 1 or 2%, for example. Another important thing, and I'm coming to the end of this presentation, is about governance. Because all the AI companies currently, whether we're talking about Amazon, whether we're talking about Anthropic, whether we're talking about OpenAI, or whether we're talking about DeepSeek, whether we're talking about Grok, all of these mega companies are on a race which they can't stop. They would all like to slow things down, but everyone knows that if they each individually slow down, someone is going to be making huge advances and they will be left behind. This fear of being left behind or fear of missing out means that many of these companies are just ignoring the governance. But in any AI system, especially when it's used in healthcare, with all its regulations and checks and balances, it's unfortunate, but you cannot bolt governance onto AI after the horse has bolted. You just can't. And that has become one of the major problems of that plague many healthcare systems, because they realize that they would love to have governance and infrastructure in place before the deployment of AI, so that they can monitor things after the deployment, but perhaps they don't have the money, and perhaps they are just driven by other, perhaps more political concerns to get the AI
1 minute,
going.
Dr. Nigel. 1 minute. 1 minute, Dr. Nigel.
The last thing to say is that building the tool is the easy part, but redesigning the diagnostic pathway is the work. So the workflow and how we use AI in diagnosis decides the value of it. And finally, will AI replace doctors? I think that's the kind of wrong question. The right question is, which parts of medical work will AI expose and automate and strengthen or devalue? Routine pattern recognition may be devalued, and clinical judgment, either with or without the human in the loop, may become more valuable. If the last thing to say is that the future will not be about AI or artificial intelligence alone. It will depend ultimately on outcomes, on safety, on trust, and on humanity. And as Marcel Proust said, the real voyage of discovery in this healthcare sphere is not in seeking new landscapes, but in having new eyes. Thank you very much.
Thank you, Dr. Nigel, for this amazing talk. May I invite also Dr. Iman to the stage to have the question. We'll start with Dr. Nigel till we see Dr. Emma. Dr. Nigel, what is the gap between how AI perform in research paper versus how it is actually performed in real clinical environment?
I think there is it's a good question. Performs in a real world scenario, and that's similar to the way that as doctors we look at clinical trials and see how drugs perform, with their percentage improvements, and how they have a different experience in real world experience, which is why we have such a preponderance of papers now on real world experience of real doctors in real places using the drugs compared with trial work. So that's very true with AI as well, because when AI is used in research things, the people that are using it, they're really quite savvy and they know exactly what they're doing. But unless the people applying the AI in hospital settings or clinic settings know exactly what they're doing, they may not be using the bells and the whistles or using the AI properly, and therefore there will be perhaps difference in outcomes.
Yeah. Dr. Emma, what does a successful medical graduate look like in 2030? What skills matter most that we are not currently making the priority in it?
So I think that I had hopefully covered some of that in my talk. I think it's that what we're dealing with is that you can't just be a regurgitator of knowledge, that alongside the fundamental bit is that you've got to be able to have ability in critical thinking, got to be able to be adaptable, that it's about digital confidence, it's about population health awareness. There is this bit about uncertainty and comfort with uncertainty and being able to manage that. Really, it is about collaborative leadership and this sort of professional adaptability. So there are the sort of core critical skills of being a doctor. And I think fundamentally, always going back to basics of history examination and investigations. AI is there to complement, it's not there to replace, it's there to inform and not replace. And it's the ability to be able to use it as a complementary and useful tool, not to make doctors redundant in that respect, but to use that tool, which I think has just been beautifully described by Nigel in terms of how you use it alongside your practice, but not to replace your practice.
Thank you, Dr. Emma. Thank you, Dr. Nigel. I'm sorry we are short of time. We need to jump to the next session. Thank you so much for your kind knowledge today. And may I instruct everybody else to move to the session 7 about rheumatology. Thanks, everyone.
Thanks.
titled Talking About Rheumatology. I'm really sorry, we've got to make it quick because we're short on time. I would like to introduce our moderator for this session, Dr. Humaira Bacha. She's a consultant rheumatologist at Mubadala Health, Dubai, and she's a US board-certified consultant rheumatologist with over 29 years of global experience across the USA, Singapore, and the UAE. Please join me in welcoming Dr. Humaira to the stage. Thank you. The floor is yours, Doctor.
Thank you so much for the introduction. Today we have an exciting session. We want to get through everything, so we're going to keep the introductions brief. We have 3 titles and talks today on rheumatology, osteoporosis, autoimmune diseases, and their management. Our first speaker is the very eminent Professor of Rheumatology and Clinical Lead, Professor Anthony Chan, who is coming to us from the Royal Berkshire NHS Foundation Trust, UK. He's a very well-known in the field of rheumatology around the globe, having had multiple papers, sits on various committees, including the GRAPPA, and also has been teaching us and talking to us over many years. Welcome, Professor Chan. We look forward to your talk on the management of osteoporosis.
Thank you very much for the warm introduction. And I'm going to talk to you about medical updates in osteoporosis. So what I'm going to cover in the next 20 minutes is to give you something really practical and pragmatic that you can use in your clinical practice. So we are going to talk about the global prevalence and burden of osteoporosis and how we can use tools such as the FRAX and the bone mineral density, the DEXA scan, and also the new and emerging therapies. And I'll share with you some cases from my clinic. Why does it matter? Because here are the stark statistics. 1 in 2 postmenopausal women will fracture, and 1 in 4 of men over 50 will fracture, and 1 in 5 people will have a mortality 1 year after having a hip fracture. So these are not necessarily benign conditions, and it requires some attention. And if we can try to prevent, this would be good. And I think a lot of what we are doing here will be risk assessment. So firstly, about the T-scores and the Z-scores. So osteoporosis, as you know, is defined as the T-score of less than -2.5. So these are people with osteoporosis. And if you got a fragility fracture, we call that severe osteoporosis. But what happens when you request a bone density scan, you also get something called a Z-score. Sometimes we wonder how we would use that. This would be used for people who are premenopausal women and men under the age of 50. It can also be used in children and adolescents. And this is useful for secondary osteoporosis screening. So if you look at your Z-score, which is less than -2, below the expected range for the age, you would want to consider whether there's any secondary cause for this. So T-score, useful for older adults. Z-score, uses for people of any age, particularly younger patients. So we also have something called the FRAX score. You may have encountered this before and you wonder, what does it actually mean? So let's look into this. So the FRAX score on your left, you put in these variables such as age, weight, height, previous past medical history, smoking, rheumatoid arthritis, as shown here. And then you come up with a 10-year probability of having something called major osteoporotic fracture, or MOF. And also you get a calculation for your hip fracture. So this works on a rule of 10. So if you're 10% risk, if your risk in the next 10 years is less than 10%, then you would be in the green. So you would give lifestyle advice. If you're between 10 to 20, then you would consider doing some further investigations, such as a DEXA scan. And if you're more than 20, then you should treat these patients because that's a high risk. And if you're more than 30, that's a very high risk. Now, you also have a hip score. Now, the hip score weighs higher. So if you got a hip score of greater than 4.5%, that immediately puts you in a high-risk category. And these people should be treated. Not only that, we should be thinking of anabolic agents in this very high-risk group. So practice points. Firstly, the FRAX score can be useful if you don't have the BMD yet. And in some people, you want to go on and do the BMD, bone mineral density. A few things, if you're on glucocorticoids, more than 7.5 milligrams a day, you need to multiply this risk by 1.2 in the hip. and 1.15 in the major osteoporotic. So you need to make some adjustments for glucocorticoid use. And also, if you just had a recent fracture, that increases your risk. The frax probably underestimates your fracture risk if you just had a fracture. And very important point, we don't use frax to monitor treatment response. The frax was first developed in people who were not treated, and that's because it's based on a population study. We do use them for reevaluation, but it shouldn't be used solely for monitoring treatment response. Okay, so the frax is available globally. This is why we recommend using this in your clinics. And so if you are from the Gulf or the UAE, this was validated in 2019. It uses country level information, so you can choose the country, the region, and select that. A few things of note, if you are practicing in the Gulf region or the UAE area, that there is quite a high prevalence of vitamin D deficiency. We recommend checking the vitamin D and then making sure that you replace that, because the low vitamin D can increase your risk of fracture. Secondly, you need to go into there and choose the national, so you would use Arab ethnicity for the frax calibrated. Now you will see, I'm sure, a lot of expatriate population, South Asians, European in where you work. And it's important that you use the country where they came from when you select the frax. So these are some practical tips here, and follow them up by a maintenance dose. Use your frax risk. You don't have the BMD, so you can measure it. And if your frax risk is more than 20% for the major osteoporosis, measure the BMD in these patients. And if the BMD is less than 2.5, consider treatment, and also counsel them about diet and exercise as well. So these are some practical tips for you. Okay, what's new in osteoporosis? In the last 2 years, there have been two key areas. Firstly, the NOC, which is the National Osteoporosis Guideline Group from the UK, and also the Australian group has also published some key guidelines. What are the new things? Firstly, they have defined what is high risk. High risk is your frax, MOF, your major osteoporotic fracture greater than 30%, and your hip fracture greater than 4.5%. Now, HRT, we used to use them and then it went off fashion. They've come back now, particularly in women who are younger women, postmenopausal, but nearing the age of 50. This could be an agent that could be used, particularly if they have low cardiovascular or breast cancer risks. And abaloparatide is a new PTH analog that's come along. And also there are new changes with frax to adjust for other factors, including ethnicity and some of these other conditions. Then there's also something called trabecular bone score. One of the issues about doing bone mineral density, if you do the spine and you have a lot of osteoarthritis, it can give you a falsely high BMD at your spine. So you can, where available, if you have the trabecular bone score, that gives you a better reading of your spine BMD. It's clarified now that the drug pause or drug holiday is for bisphosphonates only. We should not do this for denosumab. Denosumab treatment is long-term now. We don't stop after 5 years or 10 years that we used to do before. And similar in the Australian guidelines as well, they have removed strontium as a therapy, and also they have very similar recommended anabolic agents such as abaloparatide. And we'll talk about romosozumab as well for the high-risk group. So it's about risk stratification. It's about finding out where these patients are and then using the appropriate therapies. Okay, so here are all the drugs that we have currently. We divide them into, on the left, anti-resorptives. So these drugs work on the osteoclast. Bisphosphonates are our first-line treatment. We've had them for a long time. Alendronic acid is available, risedronate. Also, you can give it in an intravenous form if the patient has difficulty with taking the tablets, and these are used first line. In patients who have renal impairment, and the eGFR is about 30, then we would prefer to use denosumab rather than the bisphosphonates. So this is second line. This is subcutaneous treatment every 6 months. Remember, I talked about HRT. Don't forget that in women below the age of 60, after the menopause, you may consider this treatment as a part of your treatment goal as well. And then in the middle are the anabolic. So these work on the osteoblasts. We've had for a long time teriparatide, which is the PTH 1 to 34, and that's anabolic agent. We inject daily for 24 months. It increases the BMD very rapidly. What's new is abaloparatide. This is a PTHrP analog, and this again increases bone density very quickly. It's similar to teriparatide, and this is for 18 months. And the new one is romosozumab, which is a sclerostin inhibitor. Sclerostin inhibits the osteoblast, so if you can block it, the osteoblast can then function again. And this can reduce vertebral fracture by 73% at 12 months from the FRAME study. Word of caution, if they've recently had a myocardial infarction or stroke within the last year, then you probably should exercise some caution in using this. In people with past history of MI or stroke, you can use it so long as you do a clinical assessment for their cardiovascular risk. So which treatment shall we use? First line will be mainly bisphosphonates. If you had a recent fragility fracture and your risk score goes up, as in your MOF or your FRAX goes up to 30% and you get a fracture, then I would suggest using an anabolic agent because these are more effective for this group of patients. In people with renal impairment, denosumab would be the treatment of choice in this particular group, and consider HRT for your younger patients. So romosozumab, we need to know about this because it's a new mode of action. It's fantastic to see the science that we've learned about the bone and how these are agents. So we had rangligan, we had denosumab, now we have sclerostin, which is the blocker would be romosozumab. And you can see here pooled studies. So from the two studies, the FRAME study and the ARCH study, you can see the improvement in the bone mineral density is superior in romosozumab compared to teriparatide, compared to denosumab and alendronate. So these are pooled studies from the two studies here, quite seminal papers. They have been around for a while, but now we're starting to use in our clinical practice. Who do we use it for? These are people who are high risk, people who have a MOF of greater than 30%, fragility fracture, and a hip percentage of greater than 4.5%. High risk of further fractures, we would certainly consider using romosozumab. A few things, check their cardiovascular history, discuss with the patient, and also have a dental assessment prior to treatment. So in summary, for these treatment arms, you assess your patient. Again, it's about risk assessment. If the patient's very high risk, you may consider anabolic first, and then you follow up with the anti-resorptive. So the anabolic treatment, you usually follow up with giving them IV zoledronic acid or denosumab. And in these patients who go on to these treatments, such as the bisphosphonates, we usually recommend having a break, a holiday for 2 years. And if that's 5 years on oral and 3 years with the IV, and you can monitor bone turnover markers, or you can also measure DEXA scan depending on the availability in your area. So do not stop the denosumab. And in bisphosphonates, you can have a holiday. And this is mainly to prevent atypical femoral fractures that can sometimes happen with prolonged osteoclast inhibition. Okay, so I'm going to talk to you very briefly about 3 cases in the clinic. This is a 68-year-old lady. She has an acute thoracic back pain. She's got a vertebral fracture. She's a non-smoker. She's not had bisphosphonates before. And the vitamin D is low, and the eGFR is 55. So what do? We measure the DEXA. She's got severe osteoporosis, and her FRAX score shows that she's high risk. So this patient, she's got fracture. She's got high risk. We've excluded some secondary causes. We've treated the vitamin D deficiency. So in this situation, applying the guidelines that we've just discussed in clinical practice, we would consider using an anabolic agent, such as romosozumab. We would treat the vitamin D. We would do the calcium and supplementations. This is in subacute fracture, so the vertebroplasties would generally work for people with more acute fractures. So this is the application of the diagnostic test and how we would treat the patient. Another patient who comes to clinic, this one is 74 years old, and she's been on denosumab for 5 years. and was given advice before, which is true. Prior to this, we used to say stop at 5 years. Now she's developed breast cancer, and the oncologists have suggested stopping the denosumab before she starts the chemotherapy. How do we transition safely? So it's very important to know that when you stop the denosumab, there's a rapid rebound in the resorption marker. So these, you lose a lot of bone density very quickly. So you need to consider what you would do. So this patient is going on to drugs such as aromatase inhibitors. These are going to increase bone loss. So what we would do is we would consider giving her IV zoledronic acid for this patient. It's very safe. It can help with her bone pain as well if she's got any skeletal metastases. Check the EGFR, and then I would check the urinary CTX, which is a resorption marker at 6 months to ensure that it's suppressed by the zoledronic acid. And if they start the aromatase inhibitor, then I would continue with the bisphosphonates, and I would probably come back to denosumab later on once they complete their cancer therapy. Third case is glucocorticoid-induced osteoporosis. This is a rheumatology talk, so a lot of our patients like polymyalgia rheumatica, giant cell arthritis will be on prednisolone, so we can treat them using this protocol. So if you got a more than 7.5, the FRAX score in these patients, so in these patients you can go on to bisphosphonates, make sure they have adequate calcium and vitamin D, and then repeat their bone density scan at around 18 months to check that they are not losing any more bone. If they are, then we want to consider going on to possibly an anabolic agent for this patient. And once they stop their polymyalgia rheumatica treatment, you want to reassess them again to see whether we need to continue long term. Okay, so bone turnover markers or BTMs, you have two types. One is on your left, measuring resorption, and also one measuring formation. So the P1NP, these is used mainly if your patient's on anabolic agents, teriparatide, romosozumab. You want to check that it goes up. So that if it goes up, there is increased osteoblastic activity. And then you can use CTX, which is for osteoclast activity, and you want to suppress it. So you want the osteoclast activity to go down. So if your CTX is falling after you've had bisphosphonates or DMAP, this would be a good sign that you are responding to treatment. A couple of things about DEXA. Minimum should be at least 2 years. I wouldn't repeat it too early because you will not see a lot of significant change in terms of the DEXA scanning. Again, FRAX is not a monitoring tool. We would use the DEXAs and BTMs for monitoring. Okay, so what do we know in key points in everyday clinical practice? If you see a patient, first thing to do is assess their risk using the FRAX score. You can measure this, do document what the score is for major osteoporosis and also for the hip, and then you can do a DEXA scan if they are greater than 10%, and then monitor them in terms of treatment. You can use bisphosphonates. High risk, I would go for anabolic agents. If they're on glucocorticoids, you can start bisphosphonates. Younger patients, think about HRT. Safety, monitor their renal function, dental assessments, and you can use bone turnover markers. Home messages, here are my points. Firstly, risk stratify with FRAX. Anabolic first in high-risk patients. Don't stop denosumab. HRT in younger women. Always measure the DEXA for monitoring. Make sure you use the right population for your FRAX. And finally, don't forget to refer these patients also to your local fracture service if there is one locally. Thank you very much.
Thank you, Professor Chan. That was so concise and perfectly on time. So that saves us time. And we are going to go to the next speaker. Really appreciate your talk. It gives me great pleasure to introduce a well-known rheumatologist in the UAE. Dr. Adhikary Al-Ansari has been here for several years, leading research education in the region. He's a consultant rheumatologist at Mediclinic Airport Road. He asked me to keep his introduction short so he can go through more slides. So welcome, Prof. Ansari, and we look forward to your talk, talking about autoimmune diseases and laying the stage for their management in the next talk.
Thank you, Dr. Humaira, and thank you to the Royal College for this invitation. This is a homemade talk, which means I'm aiming to simplify the descriptions of autoimmune disease and what we mean by that. And particularly, there are a lot of non-rheumatologists attending today. So the idea to make a better overall understanding. In the last 20 years, there are a lot to describe, advances in discovering the pathophysiology of autoimmune disease. This slide only to tell you there are two major groups. One is the autoimmune on the right, the blue, which basically associated with antibody production, like lupus, like rheumatoid, like some vasculitis, and so forth. While on the left is what we call the autoinflammatory. There is inflammation there, but there are no antibody triggers. It's mainly rely on what we call innate immunity compared to the acquired immunity on the right. There are some conditions in the middle having feature of both, but the main message from this slide is, for us as rheumatologists, the steroid use. The autoimmune disease, they respond well to steroids, while autoinflammatory usually useless. Conditions in the middle, like ankylosing spondylitis, don't respond much, while Behçet's or Still's disease could improve further. So this is being unraveled by the nature of cells involved. If you look at the right, there is a T and B cells involved in the pathophysiology, triggered an immune process associated with some antibody production. While on the left, autoinflammatory are mainly the macrophages, dendritic cells, and have the pathways through what we call interleukin-1 or through IL-23, interleukin-23, that are more of the natural process of inflammation, still could have environmental trigger of some sort. So the cycle of autoimmune disease, they are initially genetically, a genetic backup for it, predisposition, could be influenced by environmental factor, could be influenced by some hormonal or other changes in the body or comorbidity, lead to a cycle of triggering cells cytokine, that eventually lead to a disease process and affecting many organs. So when I put that, many people ask environmental factor, does that mean specific food? This is the most difficult question to answer. However, when we go to autoinflammatory group, they are of two types, either monogenic, which means like affected by one gene, like familial Mediterranean fever and periodic fevers, TRAPS, and similar ones, or polygenic, which is like Behçet's disease. Polygenic is many genes need to come together before expressing the disease. Monogenic are more rare, but dependent on the genetic expression of their features, while polygenic could have variable presentation because there are so many genetics involved. That's the key message we take from this slide. And this is, again, to simplify our concept. That's a familial Mediterranean fever. Yes, there are different genes involved, but the different genes expressing similar feature means at any one person with familial Mediterranean fever, there's only one gene expressed. But there could be like another form of familial Mediterranean fever, not in the East Mediterranean, that are in Bulgaria or Spain or others. They might have a mild form of this condition. While the other example as we speak, Behçet's disease and Sapho syndrome and some other disease in the middle group, which we are classify them inflammatory, but have features of auto-inflammatory at the same time, between autoimmune and auto-inflammatory. So one study, how this description to the disease process started by Professor McGonigal, and he is in Leeds, based in Leeds, and Barbara Ansel, one of the leading research rheumatologists in UK. They did study what classified as Still's disease. And the Still's disease, they discovered there are many conditions who are not really Still's disease, but there's a background of other conditions like ankylosing spondylitis, like other autoimmune disease, but could present in some way similar to Still's disease. And that has created a big question of how we classify Still's disease in that sense. Is it by entity by itself? You know, Still's disease causing systemic feature, unwell, fever, headache, pharyngitis, as well as a skin rash or joint pains. So these are all could fit in many categories. And here, these are descriptions of, again, auto-inflammatory, and even more recently, have the new description of VIXAS, which is also genetically dependent, and also including, as I said, adult onset Still's disease. Adult onset disease, is it the same or different from pediatric Still's disease? This is an important question we'll talk about. So when you have any, let me say, immune genetic predisposition lead to immune irregularities, you can either go to what we describe leading to inflammation, and this inflammation could cause diseases, inflammatory disease, or could even lead to cancer. One example like lymphoma, or could lead to hypersensitivity pathway, or could be just autoimmune diseases as we speak. So the environmental factor here, smoking is a well documented for rheumatoid arthritis and many rheumatic disease. So smoking cessation is part of management plan to most rheumatic disease. When it comes to diet has been always difficult to prove in a clear-cut evidence. There are a lot of speculation, this one or that one. The problem is that you need to measure dietary component and make it linked to a disease process and activity to make sure that link is correct. The only major observation, perhaps, having a lot of purine and red meat in gout, that is by itself is clearly described. Stress, in my opinion, is one of the major factors that lead to trigger, sometimes initiation, and sometimes, and most of the time, trigger of the disease process. So I rely, when I called my title as mapping, I try to put a map for you in order that you can understand what we are talking about in much clearer way. So the first thing is Treg, T regulatory cell. And this, you know, the latest Nobel Prize was on the project on Treg by reformat or resetting the immune behavior of this Treg. And that's instead of trigger all inflammatory pathways by abnormal immune response back to normal, just like you have a virus in your computer. So you do reformat your computer, then it functions normal again. So that is a massive work, and that's perhaps is the principle somehow of some new advances called CAR T cells or T cell engagers. I'll leave the talk to Dr. Francis to talk about more of general advances. But then if you see on the mapping, there are another trigger of another group of cells like gamma delta cells, like lymphocyte 3 cells, like macrophages, neutrophil, and this lead to a cytokines and the trigger a pathway of cytokines. One of the group of cytokines you might need to see this group, for example, start with the first one, which is prostaglandin E. Prostaglandin is the effect of non-steroidal anti-inflammatory. So the main message when we give non-steroidal anti-inflammatory is part of as a treatment, not as painkiller or not as, you know. So that is important when the rheumatologist describe non-steroidals is there for purpose to mitigate certain part of inflammation. But then you have interleukin 1, interleukin 6, and interleukin 17. It depends on which disease process you have this predominant pathway, let me call it, interferon as well. So we'll have different diseases, have different pathways that trigger them. But there is always a predominant one. And I'll come to the concept, there is no single pathway for a single disease, but there is a predominant pathway to some diseases. And then what are the new therapeutics going to do is to block a pathway. So we block tocilizumab to block interleukin 6, abatacept to block T cell stimulation, anakinra to block IL-1, and so forth. Rituximab to effect on the beta cells, B cells directly. So that's how the map start to get clearer to us. But what are the utilization of this? Of course, utilization in the way that industry investing in a project to go to a certain pathway, try to block it. That's when we call it in a previous immune suppression medication is as a rifle effect, while the new autoimmune, the new therapies are mainly as a sniper effect or precision medicine. So that's what we need to go forward because we get more results. This is a description of some pathways we tell you, and now it's become our job as rheumatologists. We are more aware of this, and we have to choose the right pathway to block. And that could be in some diseases nominally clear, but not always is it clear which pathway block. But the story is not that simple. Are these pathways interchange or interengage between themselves? So we have this condition with psoriasis. We know IL-17 through the effect of Th17 cells. If we block it, we will achieve good improvement. But what happens sometimes, there is other pathway is get triggered, and this lead to eczema, which go through IL-4 and IL-5 and IL-13. And this process well documented, and what we describe here is immune pathways that play part between these two conditions. And to make that clearer, you see the dendritic cell, when it goes through IL-23, then IL-17 pathway to express psoriasis. If you block that one, this could be the dominant pathway. If it's blocked, the less dominant pathway, which is IL-4 or IL-5, then get more active and then lead to patient having eczema. And it's not in every patient, of course, but this phenomena has well been described and seen. The other issue is that manifestation of disease. For example, we describe ankylosing, now we call it axial spondylitis. So there are systemic features. Some people with ankylosing spondylitis, usually they come with the joint pain and bone erosions, but occasionally they have systemic feature like fever, headaches, unwell, and so forth. So some people work on that, but there is a spectrum of these spondyloarthritis, and uveitis, one of them. Enthesitis now is the main description we use in these conditions. So this is something we might need to be aware when discuss with a rheumatologist. And this is the main feature in ankylosing spondylitis. Now, the scientists reach a description that articular feature are in relation to the IL-17 pathway, while systemic feature could be in relation to the IL-6, IL-1, and anti-TNF. That explains the description by Professor McGonigal earlier that they presented with Still's disease like IL-1, IL-6, very active, but then they found they have ankylosing, then IL-17 become the predominant factor or the main manifestation related to it. So here I present a case similar to what we described by Professor McGonigal. And this gentleman was with our pediatric rheumatologist who left the country, Dr. Khawaja, and who had a Still's disease-like feature, who had IL-1 and IL-6 to block the systemic features. And only after 18 and with recurrence of symptoms, he has sacroiliac MRI, which prove involvement of the sacroiliitis. And then he goes into IL-17 and most recently JAK inhibitors. This is exemplify that all pediatric Still's disease, we need to be vigilant. Are they truly just stills, or they are systemic manifestation of something else, which is an important concept for us to think through. And another condition in that respect, systemic features in ankylosing spondylitis could include fever, as we speak, and well-being, and so forth. The important part is, do we treat this with the IL-17 inhibitors, or what? How should we treat it? Because there's a study done there. They say the common biologic treatment might not improve the whole spectrum of manifestation. Improve the joint symptoms, yes, but the systemic feature, they added colchicine and they found good response to colchicine treatment in addition to interleukin 17. And this is another paved the way that we might need to block two pathways in the same disease. I'll go quickly on this. This is a description of pathways. I'll leave it to Dr. Francis. But I have this patient who presented to me as periodic fever, which is, or people might describe still disease or periodic fever or FMF, different description. He had mainly systemic manifestation with pharyngitis. But when he came to our hospital, he had pericarditis and myocarditis. So initially, I said to optimize the IL-1 blockade and prostaglandin blockade, so I increase the brufen and colchicine based on the initial diagnosis. We did not offer that steroid because, as I say, steroid is not great in auto-inflammatory condition. But the cardiologist there, when asked me, I say, look, there is myocarditis, pericarditis, and pulmonary hypertension. Pulmonary hypertension is not a recognized manifestation of auto-inflammatory disease. So we looked into it again, and we checked some other inflammatory markers, which we call them fibrinogen, C3, C4, ferritin. And the ferritin was only moderately high, but the C3, C4, they were very low, and with the hypertension, pericarditis, myocarditis, and he had some antibody positivity as well. So I reached the conclusion that there is a lupus pathway also activated in addition to the IL-1 pathway. So initially I was thinking to give him a more biologic to block IL-1, but based on these features, I said to block the lupus pathway, which is, we call it a BLyS inhibitor, that would make the better value. Adding to that, he responded very well to infusion of steroid. And this is what we mentioned earlier. Steroid for antibodies are very good, autoimmune disease, and not very good in the auto-inflammatory. I'm coming close that the last pathway we talk about, and we have now many products, is the lupus pathway. That's when the T cell trigger the B cell and the B cell trigger antibodies. We don't know the antibodies are the causative for the symptoms or the byproduct of the symptoms. However, blocking the pathways around the B cell is the key so far, and we have so far 3 medications. We use either interferon before the B cell or on the wall of B cell, or BLyS after the B cell charges or signals. And that has, we have the options here, which are yet to get more experience with all of these, but we start using them. And there are trials ongoing by adding 2 pathway blockade. One is rituximab, or 2 points of blockade. Rituximab and belimumab, which is the BLyS, either anti-CD20 and BLyS or together. What is also interesting, there are some trials on IL-17, which goes through the blocking the TH17 product, and that would give us some new concept to talk about. We know between rheumatoid and lupus, rheumatoid have what you call the erosive disease, cause erosion of the bone, while the erosions in lupus arthritis is minimal, because now the understanding is more like enthesitis-like picture. From the interferon triggered to TH17, and that's what triggered the enthesitis, which is the tendons around the joint, and why they call it non-erosive erythropathy, like Jacquet's phenomena. And the last of, pathway change, this is a case of refractory Paget disease, something sitting in the middle between autoimmune and autoinflammatory. And by previous guidelines, we used to give anti-TNF. I give IL-17 and JAK as well without working. Then I came about a recent Turkish guideline, say to use tocilizumab, which is IL-6 inhibitor. And this IL-6 inhibitor is a change of pathway. And that later on come to new guidelines in when to use tocilizumab as IL-6 inhibitors, mainly about musculoskeletal and some vasculitic features and systemic features if there is a fever. So In patient, there is some feature could be counted as auto-inflammatory, and some features could be counted as autoantibodies. Try to be quick within time. This is checkpoint inhibitors, and this is well-recognized condition. They cause arthritis. Why is that? Because the oncologists block a receptors called PD receptors, and just to go back there, and when they block that, there is further signal go to co-stimulation, and that lead to arthritis, and this arthritis would be very synovitic, very aggressive arthritis sometimes, but less erosive than primary disease. And they have guidelines. We can use biologics as well, despite they are on the oncology side, but they allow to use biologics for arthritis as a short term if possible.
You have 2 minutes, Dr.
Yeah. This is just the concept of blocking two pathways, still not workable for now, either not extra advantage or maybe not as safe, only occur in what we call Galaxy study in inflammatory joint disease, ulcerative colitis, when they successfully get better results with combination of guselkumab and golimumab and being licensed for that. That's when you block two pathways. And just I'm not going to talk more about that, but this is the new concept, is by adding to pathway blockade if possible. And there will be more exciting views from Dr. Francis following me. Thank you very much.
Again, for your great talk. And I mean, we've been having amazing speakers sticking to time. We have our final speaker, Dr. Francis Pearson, Kynaston Pearson, who has come to us recently from the UK, having qualified there and worked in Derby and Burton as a consultant. He's a consultant rheumatologist at Mediclinic Parkview Hospital, and he's here to talk in advances in rheumatology disease management. Welcome, Dr. Francis.
Assalamu alaikum, and good afternoon to everybody. Thank you so much for the invitation, and thank you very much to my other panelists who really helped set me up for today. We have a lot to cover, so I'm going to go straight into the slides. So I'm going to talk about advances in rheumatic disease. The intention here is to start from some basics where perhaps we're all maybe familiar with some of these areas, then to get a bit of a peek behind the curtain about what is happening inside the rheumatology clinic before discussing some emerging practice and advances. I'm going to try and cover as many areas as possible in the time: inflammatory arthritis, connective tissue disease, vasculitis, and if we even get time, some notable mentions. My disclosures, none are relevant to today. So we're perhaps familiar with the idea that joint pain can be inflammatory or non-inflammatory, with those features on the left side being inflammatory sounding features, so morning stiffness, redness, swelling, heat, response to movement, NSAIDs, seronegative or CTD features. By all means, refer any form of joint pains, but certainly rheumatologists should be seeing inflammatory arthritis cases. For those that come to see you in the clinic who you think might need to be referred, it's useful to obviously get a basic history before you're sending them on to us. Do consider sending some antibodies like rheumatoid factor, CCP or CRP, because it can be helpful. And of course, uric acid if you have any concerns about gout. Now, I will add that if you have a monoarthritis and it's not obviously gout, have a very low threshold to refer these patients in. They do not need to be especially sick for this to be a septic arthritis, and we absolutely must not miss that opportunity to get them referred. If you can avoid steroids because they're going to be seen fairly quickly, that's great, because it can mask what we find in the clinic. When you're looking with crystal arthritis, this is the most common form of inflammatory arthritis, and perhaps one that we may feel comfortable managing without having to see a rheumatologist in some cases. Now, the gold standard is to take some fluid out and to look at it under a microscope for polarized light microscopy so we can confirm the type of crystal we're dealing with. But actually, we can use ultrasound. These crystals form inside the cartilage or on the surface of the cartilage, giving a characteristic double contour sign. And more modern technologies like dual imaging CT can not only identify the crystals, but even the subtype of crystals with high sensitivity and specificity. Early treatment, I think, is recommended, perhaps even after their first flare if there's not been an obvious precipitant. Now, we have to remember that this is a metabolic disease, so screening for diabetes, hyperlipidemia, hypertension, obesity, and managing those is all part of treating gout. If it's a simple case of xanthine oxidase inhibitors, you could perhaps just treat yourself, but if they're on multiple drugs, uricosuric agents or uricase agents, I think a rheumatologist should be involved. For those who come to see us for inflammatory arthritis, we'll obviously run through the history. We may do a bedside ultrasound. And pretty early on, if we think we're dealing with an inflammatory condition, we'll be working these patients up for DMARDs with virology testing and x-rays, because early treatment and early escalation has been shown to lead to better outcomes. Typically, we start with a DMARD like methotrexate, but we now are introducing biologics much sooner, following guidelines like ACR and EULAR with their approach of escalation. When we're monitoring our patients, we're using a standardized disease activity score like a DAS28 or a DAPSA, and then we're looking at giving them the standard advice on which vaccines to have and to avoid, and monitoring for cardiovascular risks which can be associated and bone health risks which are higher. But more advanced practice is perhaps looking at more treated disease according to the phenotype. So this is particularly prevalent in seronegative disease like psoriasis. We're using biologics more rapidly and with lower disease activity, having multi-specialty clinics, or even treating people before they have clinically evident disease. So this is the best example of treat to phenotype in inflammatory arthritis. At the top here, you can see the types of disease manifestations from eye inflammation, bowel inflammation, nail disease, joint disease, spinal disease. And there will be certain biologics that work better than others. For example, eye disease, we would like to use TNF drugs. If there's bowel disease, we might avoid IL-17 drugs because they do not work and they may even make it worse. If we need more rapid onset, we could be using JAK inhibitors. So do we have the same in rheumatoid arthritis? Well, not quite, but you can see here on the left, as we've just heard about the mechanisms, we have some of the different types of biologics, some of the potential benefits and some of the potential pitfalls of these individual biologics. So this helps us somewhat select for the patient. How do we make a choice clinically? The antibody status can be helpful. If they're producing antibodies, then it's likely that there's going to be B-cell involvement since they're producing the antibodies, hence rituximab may be useful. If the CRP is extremely high, this may be IL-6 driven since IL-6 produces CRP from the liver. We may see a very aggressive or rapid disease onset where we really need a fast-acting agent, and JAK inhibitors are slightly faster than others. But there is also science behind this, with synovial biopsies potentially going to help guide us by looking at the disease pattern on a cellular basis, or perhaps markers that will tell us which type of disease they have based upon the cell pickup in the biopsies. Should we be using TNF first line as our first line biologic as it is cheaper? Well, I think it's fair to say we should have the principle of medical justice in terms of being judicious about our spending. And perhaps if you can't find a good reason not to use a TNF, then that should be the first line. But as we're better understanding these diseases, and they're all slightly different, I think putting the patient on the right drug first is probably the priority. Complete care should be done with multiple other specialists. Sometimes we have this in the same clinic, for example, combined clinics with dermatology or combined clinics with gastroenterology, so that we can make the decision about the overall phenotype together in one clinic. Other updates, well, I did say that we sometimes treat before there's evident disease. A couple of years back, we have the APIPRA and ARIA trials. This is where we treated patients who had arthralgia, so not inflammation, but pain, and positive antibodies with abatacept, the T-cell drug. And we were able to reduce the number of people who went on to diagnosable rheumatoid arthritis and help those individuals. So this is kind of going in so early that we can't see that there's joint swelling. Should we be avoiding DMARDs then, since these are old-fashioned, some of them are teratogenic, they have side effects, they're not clinically as effective? Well, I think there's still a good case to continue them because they are very, very cheap. They also help us with something called immunogenicity. So using these medications slows down the amount of antibodies that are produced against the biologic drugs, so they can give longer survival. And it's not like biologics don't have side effects themselves. What about inflammatory back pain, axial spondyloarthritis? Well, we still have a big challenge here. It takes a long time to diagnose this. HLA testing is not brilliant, especially in this part of the world, and X-rays take a long time to see change. So MRI has been heralded as perhaps the real savior here, but this study that was published this year has raised some concerns. In this particular study, they found that up to a third of patients had changes on the MRI that you could diagnose as inflammatory back pain. So it does raise some concerns about how do we get the diagnosis right. Now, in modern imaging techniques, such as looking at fibroblastic activity using PET scan, may be the future of how we can do this, but it hasn't been properly validated yet. Also, At the moment, PET is often done as CT PET, which is obviously irradiating, and doing this by MR PET would be preferable because you would also get the edema, which I don't think is available in the UAE at the present stage. What about bone scans? Well, they can be used if MRI isn't feasible. So, connective tissue disease. CTD features to watch out for in the clinic are these listed here. So photosensitive rashes, particularly the typical butterfly rashes, alopecia, Raynaud's, blood clots, and so forth. Obviously, we have the ubiquitous ANA positive, unclear of what the cause is, that often come to our clinic, which is fine. From a generalist perspective, I would say it's helpful if you can do some extra antibodies, such as these listed here. But what is really useful is just doing a simple urine dip. If they have proteinuria and hematuria, that is going to help us to determine if they have evidence of end organ disturbance and also the urgency with which we need to treat. By all means, refer these patients with ANA positivity for clarification, but just be aware that the limitations of ANA, it does not diagnose the disease. And sometimes patients arrive in clinic quite anxious saying, I've tested positive for lupus, which clearly ANA does not test for lupus in of itself. Within lupus, we do have challenges of actually confirming it. It's good if we can use criteria like SLIC criteria to actually confirm this is lupus. But the other challenge is that we need a diagnosis in some cases for insurance to allow us to proceed to treatment. And so sometimes things like lupus get put on when you wouldn't necessarily meet the SLIC criteria in order for us to get authorization for drugs like hydroxychloroquine, which I would say is a near mandatory drug these days, not just because it's a light DMARD, but it also helps with platelet stabilization and reduction in blood clots. Obviously, with part of SLE care, we're going to monitor them regularly, provide advice on UV protection and pregnancy and contraception, and monitor them using some form of validated composite disease score. So in terms of agents, historically, we've used hydroxychloroquine, and then for joint pains and other issues that are relatively moderate, azathioprine methotrexate, and for more obvious organ disturbance, mycophenolate and cyclophosphamide. But thankfully, we have interferon blockade, which we've just been hearing about, which is particularly helpful in joint situations and also skin disease, and is presently being investigated for lupus nephritis. When we do have kidney disease, we can use triple therapy with the calcineurin drug voclosporin combined with steroids and mycophenolate, especially helpful in class 5 disease. And at the end of last year, we had a humanized CD20 blocker, obinutuzumab. So this is humanized, meaning you have less reactions, but it's also more potent. Finally, anti-BAFF treatment, belimumab, which is often combined with hydroxychloroquine, especially for lupus nephritis. Emerging practice, well, we're wanting to personalize the medicine again. We want to understand what's going on, and understanding the interferon signatures in lupus can help us to predict which drugs are going to be best for that individual patient. So other factors, well, we don't really want to have to wait until patients end up with proteinuria before we start treating them, because that means they're already getting kidney damage. So a range of biomarkers that are released before clinically significant proteinuria are being proposed for us to detect preclinical or pre-proteinuric renal involvement in lupus. In other words, what we're trying to move towards is a better understanding of the disease using transcriptomics, proteomics, and cell profiling, so that we're not just saying this is lupus or this is lupus according to the SLIC criteria, but we have a patient with a high interferon B-cell predominant lupus phenotype. Okay, in the pipeline, maybe JAK inhibitors. Now, TYK inhibition, TYK, confusingly, is a subunit of the JAK proteins. Now, these are the proteins on the inside of the cell that are affecting the outside molecules. So when they bind the interleukins, you'll go often through a JAK pathway. TYK inhibition is going to be coming online, which is one of the subunits. That might be useful in lupus, and CAR T therapy, which I'll do a quick slide on later. Okay, systemic sclerosis then. This is a fibroblast-driven disease, so it's more of an indolent, relentlessly progressive scarring disease rather than some of the more aggressive types, which makes it a little bit more challenging to treat. There are different variants you may be aware of, particularly we think about diffuse and limited, with a kind of crest variant, and antibodies like centromere or SCL, SCL75, SCL100, they can help determine which is more likely to be the case. Features to watch out for: Raynaud's, respiratory features, telangiectasia, reflux, and ulcerations in the fingers. Do consider doing an ANA, but get these patients referred early. In terms of the standard of care, apart from the full evaluation, we may be looking at their capillaries, because you can tell a lot from the microcirculation about whether this Raynaud's may be coming from something like systemic sclerosis. CT scans looking for interstitial lung disease, and echocardiograms if you have the expertise in right heart pressure estimation, which is a bit more technical. Otherwise, we might do lung function tests, barometry, and occasionally a biopsy, because unusual things present, like eosinophilic fasciitis. We can do standardized skin scoring using a Rodnan skin score, and we can use composite measures like a DETECT algorithm, which use multiple measures to determine if someone may benefit from right heart catheterization to actually diagnose pulmonary arterial hypertension. Standard of care, we're using methotrexate and mycophenolate a lot more often for skin thickening. Cyclophosphamide often being used for organ disease, and rituximab and IL-6 like tocilizumab for interstitial lung disease. Where there's vascular disease, we might use sildenafil or tadalafil, a PDE5 blocker, with something like macitentan and perhaps IV prostaglandins. And for fibrotic disease, we can use nintedanib, but it's got a lot of side effects, and many patients struggle to tolerate this. Clearly, they should stop smoking if possible. And one thing for the audience to take home is be careful with steroids and scleroderma, especially diffuse variant, because it can precipitate a rather nasty renal crisis. So emerging treatments, stem cell transplants have been used, but the literature has generally been for people with bad skin disease because of concerns that other people with organ disease may not be fit for the treatment. I will briefly touch upon a case for why CD19 is being a bit of an exciting prospect versus CD20 blockade, and CAR-T again. Okay, Sjogren's disease then. This is more of a nuisance disease for many people. Fatigue, arthralgia, malaise, and sicker features. But don't be fooled, even that those things are relatively mild compared to, say, multisystem lupus, the quality of life impacts from Sjogren's can be quite significant. There's also a significant relative risk increase of certain blood cancers. Okay, the absolute risk is not massively increased because these are rare cancers, but still we have to monitor these patients. Occasionally, Sjogren's can be multi-system, so I think the message is refer these patients up early for evaluation. Our standard of care, we're going to make these assessments and try to be as objective as possible. A Schirmer's test can look for tear production, scintigraphy for saliva production, and ultrasound of the parotid to see if there's any swelling, and a biopsy with some in-clinic kits now available that you can do. Hydroxychloroquine with saliva and tear substitutes are quite common, sometimes topical cyclosporin for the eyes, and pilocarpine to help stimulate more production of tears. We also monitor these patients regularly for lymphoma. Now, usually when it's systemic disease, we use CD20 treatments like rituximab or cyclophosphamide, and occasionally we're using belimumab, abatacept, or IVIG. But in the pipeline, there's quite a few things coming. So this new drug, inelimumab, in these Neptunus trials, has a different mechanism. This is working on BAFF, like belimumab, and directly on B cells to deplete them in a dual action. So fundamentally, this is a different drug. Also in the pipeline, we have CD40 blockers that help with communication between the T and the B cells in the ALICE trial. We have telakecept, which is a blocker of two receptors on B cells, the BAFF and APRIL. And we have a very interesting class of drugs called FcRn inhibitors. I'll talk a little bit about this in myositis. Finally, there's some tyrosine kinase blockers that have been tested, mixed results, but still potential promise in the pipeline for Sjogren's. Okay, myositis then. So dermatomyositis and polymyositis are the ones that we particularly are worried about. The juvenile variant has generally got a better outlook, and inclusion body isn't a typical autoimmune myositis. The things that you may see in clinic are the characteristic clinical features, for example, Gottron's papules on the hands, or mechanic's hands if more extreme, the violaceous rash around the eyes, so-called heliotrope rash, the plucked skin appearance of poikiloderma present in the V sign or across the shawl area, and Raynaud's. But I would say that you may just pick this up because of deranged LFTs. Remember that the transaminases could also be coming from muscle tissue. So if you find high ALT and AST, but the liver looks normal, do a CK because it might be coming from muscle tissue. Refer these patients early because they can get a frightening type interstitial lung disease. From our perspective, we want to look for malignancies in the first case because often we do find a malignancy associated. We send off a huge antibody profile because immunotyping can help us to predict the type of phenotypes that they may have. And then we're going to look for cancer, but also for interstitial lung disease with HRCTs and pulmonary function tests, because some types, particularly the amyopathic types like MDA5, can give a very nasty, rapidly progressive lung disease that needs urgent treatment. IVIG is still used, along with rituximab and cyclophosphamide, and abatacept working on T cells can also be used. Emerging treatments, there's these TYK2s appearing again as a potential emerging treatment. And again, these FcRn blockers. Now, FcRn is clearing the immunoglobulins faster. So rather than reducing the B cell population like CD20 blockers, and the B cells therefore are reduced and can't produce the antibodies, the FcRn blocker is clearing these antibodies faster. CAR T therapy, once again, showing its head. Okay, getting towards the end. Vasculitis. You're probably all familiar that vasculitis is split into the vessels that it affects, large, medium, and small, with large vessel vasculitis generally worldwide being the most common, though in this region, it does seem to be much less common than where I train back home. Medium vessel is the rarest, with mainly affecting children with Kawasaki's and often mainly being hepatitis B related with polyarteritis. And vasculitis, when we think about it, is often the small vessel vasculitis, typically the ANCA vasculitides. Obviously, recognizing these promptly is important for organ protection, but we need to know that ANCA is not always your friend, and it can be falsely positive and falsely negative. The standard of care is going to be trying to do a full evaluation of where the vasculitis is affecting you, using something like the Birmingham Vasculitis Activity Score. We want to risk stratify these patients, get in early with steroids, and then we can use targeted drugs. For example, B-cell depletion is quite commonly used, but for the eosinophilic subtypes like EGPA, we now have 2 licensed IL-5 blockers, ipilimumab and benralizumab. IVIG is sometimes used, and for the large vessel disease, we can use tocilizumab or IL-6 agents. What about plasma exchange? Well, sadly, it isn't that helpful. Maybe in the most advanced cases of renal disease and in some types of vasculitis like good pastures, it can be helpful, but in general, plasma exchange is not particularly useful. So emerging practice, should we schedule these patients regularly or when they have a flare? Should we be using that obinutuzumab, that humanized CD20 drug that we talked about earlier? And perhaps repurposing old drugs for new purposes. So IL-17 blockers and IL-12 and 23 blockers might be useful in giant cell arteritis with trials ongoing. JAK inhibition as well is being studied. This is just to say about the CD20 and CD19. This is the maturation process of B cells. And you can see where CD20 is expressed and you can see where CD19 is expressed. So if we block CD19, we are going to get a deeper suppression of B cells than if we block CD20. So that's some of the excitement towards moving towards these CD19 blockers. Very briefly, the CAR T cell therapy we've been talking about. Anyone not familiar, we take the blood, we isolate the T cells, we use a virus to introduce a chimeric antigen receptor with a specific target that we've chosen, in our case, perhaps CD19. We then grow those T cells and re-inject them back into the patients, and then you can get the depth of suppression of CD19 with the tissue penetrance of T cells. So this is a very effective way of treating. In fact, there's even been discussions of could CAR T be curative. I think that's probably a little bit optimistic. It's very expensive at the moment because it's individualized, but we are looking into whether there's any off-the-shelf options or ready-made CAR Ts. I'd love to be talking to you about GLP-1s because they're obviously a hot topic, but they also have anti-inflammatory actions. Artificial intelligence is clearly being incorporated with all of these variables, trying to mix those together in terms of immunophenotyping and predictive modeling for patients, in addition to what we're doing in the clinic. Wearables might be an area that we're looking into in terms of predicting disease flares. I'd like to cover up non-inflammatory, but we just don't have time. And it would be lovely to give you some opinions about some of the things that are happening in the UAE and locally in terms of wellness practice, some of which I think are interesting and others of which I have some concern.
Wow, take a deep breath. That was amazing for you to go through such a comprehensive coverage of all of our treatments, which I'm sure the audience benefited a lot and took some notes, I hope. We unfortunately have no time for a panel discussion. So I would like to thank our esteemed speakers, Professor Adhikary Ansari, Dr. Francis, and Prof. Chan, and hope to see you all soon. Thank you so much. And for the audience, can you kindly go on to the next session, please? Thank you. Bye, guys.
Thank you.
For today. We welcome you today to the launch of the Allergy Masterclass. We're really delighted to kick off the CME accredited educational program that is designed to provide a comprehensive and practical approach to allergy care. The program consists of 3 modules covering upper respiratory allergy, lower, and skin allergy. So this learning journey will be delivered after the RCP conference through a combination of live webinars and self-directed learnings, allowing participants to learn at their own pace while benefiting from expert-led discussions and practical insights. So starting today, the Allergy Masterclass will kick off, and then over the next 3 months, there will be different educational activities delivered throughout this program that is ought to conclude by the end of September. For those interested in joining the program later on, please contact the iConference team, who will be happy to assist further. Thank you all for being here today. We look forward to an engaging, interactive, and rewarding learning experience together as usual. Today, I am very happy to introduce my colleague, Professor Hadi Salahuddin, who previously served as a chairman of both the Otorhinolaryngology Department and the Cochlear Implants Program Unit at Qasr Al Aini, Cairo University. Professor Hadi holds an MBBCH with honors, a master's degree, and an MD in ENT from Cairo University, and he has completed advanced training at the House Ear Institute in Los Angeles. With over 3 decades of clinical and academic experience spanning in the otology, rhinology, laryngology, and head and neck surgery. Of course, he is a distinguished member of the Egyptian Society of ENT, and he is also an ENT at Cairo University, where he serves as a full professor and a consultant at Dar Al Fuad Hospital and New Giza Hospital at Cairo. So without further ado, I hand it over to my colleague, Professor Hadi. Over to you, Professor.
Thank you, Dr. Inel. Good evening, everyone, distinguished colleagues, honored speakers, and valued participants. It's a privilege to welcome you to this evening dedicated to advancing knowledge, fostering collaboration, and improving the care of patients living with allergic diseases. The number of patients affected by allergies is increasing worldwide. The resulting allergic diseases are leading to significant costs for healthcare and social systems. Integrated pathways are needed to enable comprehensive care within the national health systems. On behalf of Bayer and the organizing committee, it's my great pleasure to welcome you to the Bayer Allergy Masterclass, held as a part of the Second Road College of Physicians Global Update in Medicine 2026. Today's session brings together leading experts to discuss the latest advances in allergy, diagnosis and management, and translating emerging evidence into practical clinical applications that can improve patient outcomes. We are privileged to have an outstanding panel of speakers who will share their expertise and insights. I encourage everyone to actively participate in the discussion and take advantage of this excellent educational opportunity. Thank you for joining us and contributing to what promises to be an inspiring and informative exchange of ideas. With that, let us begin our journey through the latest developments in allergy care. It's now my distinct pleasure to introduce our first speaker, Professor Walid Farag Abdelaziz Izzat, Professor of Otorhinolaryngology and Head and Neck Surgery at Ain Shams University, and Head of the Cochlear Implant Unit at Arab Contractors Medical Center from Egypt, presenting treatment strategies versus allergic versus non-allergic rhinitis. Thank you.
Thank you very much to you and to all the organizing committee from Bayer. I'm very glad to be with you tonight. And I'm just going to ask a few questions to the audience just to trigger their thoughts. I mean, it's not a matter of just having rhinitis and you're going to write anything for rhinitis. You have to differentiate between the different causes of this rhinitis. Of course, in acute cases where you've got sinusitis and acute rhinosinusitis and upper respiratory tract infection, it's quite easy to diagnose and manage, and everybody can do it, even the general practitioner. But when we come to a long-standing rhinitis, we really should differentiate between allergic and non-allergic rhinitis. Not only to properly diagnose him, but to properly provide him with the proper medication, the proper lifestyle modification, and the proper further management if we can do that. So, number one, I have to ask, how am I going to differentiate rhinitis that is allergic from non-allergic rhinitis? I have to understand rhinitis first. So the very first thing is, itis in Latin means, of course, inflammation. So there is definitely an inflammation of the nasal mucosa. This inflammation is associated, of course, with vasodilatation, leading to the congestion. And this congestion irritates the nerve endings, leading to sneezing. And of course, the associated vasodilatation will lead to some sort of rhinorrhea. So this is the inflammatory process that goes on. How does this affect us? Of course, it's not only affecting my output as a social standard that I'm holding a handkerchief all the time, or I'm sneezing all the time, or I've got blocked nose so I cannot contribute to social activities properly, but it also affects my quality of life in proper sleep, proper enjoyment of the tastes of different foods and drinks, and in general, it might affect the quality of life itself. So how am I going to differentiate it? Allergic rhinitis, it's actually an immune-mediated inflammatory response. So you have to have a trigger of an allergen that is introduced to the body, and then your body starts to develop antibodies to it. And these antibodies, in the beginning, don't make a big difference. But when these antibodies level reach a critical level, a threshold level, then the patient starts to have the symptoms from re-exposure to the same allergy again. It is basically IgE antibody involved, okay? But non-allergic rhinitis actually can happen from the very first exposure to the triggering factor, whether it's hormones, whether it's drugs, whether it's industrial allergens or things like that. So we have to know that allergic rhinitis, it doesn't come in between overnight. It has to have a development of weeks and months and sometimes years to reach a level of antibodies that is above the threshold of development of symptoms, but non-allergic rhinitis can happen with single and initial exposure to whatever the triggering factor is. How does this matter, actually speaking? Okay, so number one, I have to know the diagnosis, how it affects the treatment lines, because treatment lines might differ a little in between allergic and non-allergic rhinitis. As we said, some things are common and some things are specific to one or either type, especially the avoidance, or especially if I'm going to change the mode of treatment of a patient. The treatment failure, of course, is going to be of very important influence, because when I have a treatment failure, I'm going to have to visit the physician again. And of course, this is a burden for the patient himself and for the company if he's insured or something like that. And this will affect his cost of treatment, of course. And the patient burden itself, he might lose his time, his effort, and of course, he might get some depression from failure to have a proper treatment line. So we'll start by allergic rhinitis. As we said, it's a classic immune-mediated response. Of course, we have classic triggers, right? Like pollen and dust and pet dander and mold. And even if you are a completely normal person and you're not hypersensitive, you still can have some sort of hypersensitivity to these things. And the classic symptoms are, put in mind, the very important symptom is the itching of the nose. Itching is a key factor in determining that this is allergic rhinitis. In other types of rhinitis, usually you don't have much itching. You might have congestion, you might have some sort of rhinorrhea, but itching is almost specific to allergic rhinitis. And nasal congestion, of course, is part of the problem. You might have nasal congestion, you might have sneezing, and of course, you might have associated symptoms and ocular symptoms like watering of the eyes. So what are the clinical features? As I said, you might have temporal patterns. That means that you might have some in winter or in summer or in fall, according to the allergen that you're sensitive with and according to the climate you are living in. And of course, other countries which have, let's say, dust all the time, like the Sahara Desert and the desert countries, you usually have perennial, which is all year round allergy. And of course, if you have allergy to indoor allergens like mold, and especially if you have types of carpet like moquette carpet, and these are very important in having molds in your house. And we really recommend that you don't put any permanent carpets in your indoor in your houses or in your office. That's very important. And of course, with the central air conditioning, that's another issue that you should really put in mind. If the patient has a central air conditioning, this is a very important trigger to allergic rhinitis, and especially it's going to be perennial. And of course, another classical feature for allergic rhinitis is the atopic march. The patient often is having not only nasal allergy, but he can have also associated asthma, he can have atopic dermatitis, and of course, he can also have food allergy. And usually it starts by one of them, and then it progresses into the other, and the third, and the fourth. Of course, how are you going to confirm this? It's a very simple test. You can do a positive allergy testing by demonstrating high IgE levels in blood. That's very easy. Of course, it's an IgE mediated response. So you can do a very simple blood test and you can do an IgE level. Of course, if you do also a complete blood picture, you might have some eosinophilia, which helps you in diagnosis. And if you want something a little bit more sophisticated, you can take the nasal discharge and analyze it cytologically also. So what are the tools that we have to diagnose allergic rhinitis from non-allergic rhinitis? Of course, the golden tool for us is the skin prick testing. It's a gold standard, and it's very easy, and it does not cost nothing. And of course, the results are almost immediate. It takes only 10 to 15, maximum 20 minutes to get your results. And you can identify the allergen that the patient is sensitive to. And a broad spectrum test is the serum IgE. And then you do the specific IgE if you're going to plan a sort of desensitization therapy. That's very important. And to know what are the 5 most common and highest allergens that the patient is sensitive to. Of course, if you can do a nasal examination and collect the nasal discharge, you can, as I said, do cytological analysis, and you'll find a lot of IgE and eosinophils. But the picture of the clinical picture of the nasal mucosa is almost characteristic by having bluish and pale and boggy, swollen, turbinate, and even sometimes the septal mucosa itself is also boggy and bluish if allergy is severe and the patient is really not under control. So how am I going to treat allergic rhinitis? We're going to the thing of allergic, not non-allergic. We're talking about allergic rhinitis alone now. Basically, of course, as anybody will tell you, the best is avoidance. So I'm going to go beyond medication. The best is avoidance. So if you can have something that you are definitely allergic to and you can avoid it, like some pets, like some molds, like some types of chemicals, like some perfumes, of course, like some foods that you might be allergic to, the best treatment for allergy is avoidance. So if you can avoid the allergen, that's going to be the best line of treatment. But of course, plenty of allergens are non-avoidable, especially if they are environmental or weather related. So what we're going to do is, the area, actually speaking, recommends a single dose therapy. Sorry, a single mode therapy, not a single dose. A single mode therapy. It's either going to be an oral antihistamine or a local nasal drug, whatever it is. If it's going to be a local steroid or a local antihistamine or a local antihistamine with steroid. But the area recommends you to start with one type of medication, all right? And then if you can control it, it's fine. If it's not controllable, then you're going to step up with a second line, maybe a third, and sometimes even a fourth line of therapy in pharmacological matter. Of course, the oral steroids are not the best to treat. If you can avoid them, that's very good, but sometimes you have to revert to oral steroids in acute cases or as an initiation for therapy. But what is acceptable for long-term is the intranasal steroids, and that's very fine, and you can use it for years and years without any apparent side effects. It's no longer thought to have any effect on the hypothalamic pituitary axis. It's no longer going to affect the growth of the patient. But sometimes some patients are a little bit sensitive to them, and you might have some bleeding nose in some cases, so you have to revert to things that are more soother than healed corticosteroids. Of course, if you're going to do other medications like leukotriene modifiers, you can do them as an adjuvant therapy. And let's say 25 years ago, they were a main line of therapy, and then they regressed. And then recently, again, in the past 2 or 3 years, they are starting to gain access more and more. For nasal decongestants, you can use them also, but not for long. You can use them safely for 5 to 7 days. And oral decongestants, let's say you can use them for a month or so, but not more than that, because they might have some side effects like hypertension and prostate infection. Beyond medication, as I told you, allergic avoidance. And if you cannot avoid, you can revert to immune therapy by desensitization, all right, and especially if you cannot avoid and you cannot control properly the symptoms by an oral medication. So you revert to immunotherapy only if you cannot control the patient with medications. Of course, because immunotherapy is costly, it's time-consuming, and it is really sort of a burden on the patient. How about non-allergic rhinitis? How are we going to diagnose non-allergic rhinitis? By definition, it is a chronic rhinitis in absence of sensitization or infection. Okay, it's in absence of sensitization of infection. So what's the key distinction of it? How can you really find that this is non-allergic rhinitis? The key is not finding immunoglobulin E. If you're going to do a laboratory test, you will not find many eosinophils in a CBC, and you will almost find no IgE elevated levels in the lab. Okay, how much prevalent is it? It's about 1/3 of the prevalence of allergic rhinitis. So if we have an environmental studies, and we say that globally, according to the country, you have 10 to 30% of the population having allergic rhinitis, 1/3 of this number in each country is going to have a sort of non-allergic rhinitis. Okay, and actually it's a wide spectrum. It's not as simple as allergic rhinitis is going to be seasonal or perennial. No, it's a wide spectrum of diseases or of symptoms. And the most controversial one of them is what we call local allergic rhinitis. You have the symptoms of allergic rhinitis, you might have the signs of allergic rhinitis, but in absence of any systemic manifestations or any systemic laboratory tests that will guide you to allergic rhinitis, like an elevated IgA level or eosinophilia in the CDC. So this is a really controversial part. Luckily, it's not that much common, but you must put it in mind if you cannot find another categorization for non-allergic rhinitis. What we really find a lot is vasomotor rhinitis, which is a neural dysregulation and vascular hyperactivity. And this vasomotor rhinitis can be, of course, from spicy foods or spicy drinks and alcoholic drinks and things like that. And it's a reaction, it's a sympathetic reaction, all right? And you have it as a side effect of many of the food and drink, especially if it's very hot food, like when you are eating capsicum or you're eating spicy food, you have a sort of vasomotor rhinitis. And of course, we have hormonal rhinitis, which usually occurs in pregnant ladies, and drug-induced rhinitis. And this is very important because we really have a large category of drugs that might induce drug-induced rhinitis. The most common is the anti-contraceptives, plenty of the antihypertensives, and plenty of those drugs that are used for prostatic hyperplasia, and of course, those drugs that are used in male impotence. All these are drugs that induce the drug-induced rhinitis. Okay, so we'll go by each of them shortly. And for the local allergic rhinitis, which, as I said, is similar in presentation to allergic rhinitis, but if you do any laboratory tests, you will find everything would be negative. The only thing that you might find, if you take the nasal secretions and you examine them, you might find some eosinophils in excess than the normal for non-allergic rhinitis. So it's really a diagnostic challenge because you will not find any systemic positive tests. But how about the vasomotor rhinitis or non-allergic rhinopathy? How are you going to diagnose it? As I told you before, it's a neural hyperresponsiveness. It's due to autonomic imbalance and with an exaggerated vascular response. You don't have any specific allergen that you can find, but the triggers are strong perfumes, strong odors, weather changes, like when you're going from an AC, a controlled environment to a hot environment in the street or something like that. Of course, sometimes with tobacco and pollution, and as we said, alcohol consumption. The nasal congestion and rhinorrhea here are predominant. There is almost no itching. As I told you before, itching is a sole character for allergic rhinitis. If you find itching in any of your patients, you don't think twice. It's allergic until proven otherwise. And how about drug-induced rhinitis? Of course, we have something very important, which is called rhinitis medicamentosa, and this is a side effect of the long-term uncontrolled use of local decongestant drugs. What happens is that how does local decongestant actually work? In the beginning, they start to close the pre-sinusoidal. Of course, we have sinusoids in the turbinates, and these sinusoids are to serve for the normal nasal cycle. And usually we have one side of our nose working and the other one is resting, and then alternation occurs within a few hours according to the environment and the surrounding conditions. If you use excessively a local decongestant in the beginning, in the first 3 or 4 or 5 days, what happens is that it has a very strong effect on the pre-sinusoidal sphincter and almost no effect on the post-sinusoidal sphincter. So it's really going to decongest your nose. But as time goes by, there is priming, there is habituation, and it starts to close the pre-sinusoidal sphincter and the post-sinusoidal sphincter. So by time, you will have to increase the dose and the priming increases, and then you will have to use the decongestant every 2 hours or 3 hours instead of 12 or 8 hours. So this is a very important problem, the rhinitis medicamentosa. And how about antihypertensives? As I told you before, antihypertensives are a very important factor, and one of them we have to put in mind is the ACE inhibitors, the beta blockers, and of course, methyl dopa and risperidine. For the anti-inflammatory drugs, you might have some patients when they use classical non-steroidal anti-inflammatory drugs, sometimes they trigger hypersensitivity in them and they start to have some sort of nasal congestion and nasal discharge. So how are you going to do with these patients? You go to the COX-2 selective anti-inflammatory drugs and avoid the classical non-steroidal drugs. Of course, last but not least, as I told you before, hormonal medications are very important, and the most important oral contraceptives, although new ones now have very small doses of hormones, so they don't really imply a burden, but the most important is those drugs that are used for thyroid hypothyroidism, or for prostate hyperplasia, or for male impotence. Of course, the male impotence, like the sildenafil, are also used for pulmonary hypertension. So you might find ladies with pulmonary hypertension taking also sildenafil. So put in mind that you don't ask for these drugs only in males, you ask for them also in older females. So how about hormonal rhinitis? Where is it? Okay, we have hormonal rhinitis, which is pregnancy. As I told you before, pregnancy is very important. And usually what happens is that in pregnant ladies, all right, when the placenta starts to develop, it secretes placental hormones. And these placental hormones, actually speaking, have vasodilator effect, which should serve to improve the blood supply to the uterus, but it's not only working on the uterine vessels, it also works systematically. So, of course, you might have her having varicose veins, and as she has varicose veins in her legs, she has some sort of varicosities of her nose, which is in the form of a hormonal or pregnancy-induced rhinitis. Of course, in ladies that have really high levels of hormones, they might have menstrual cycle-associated nasal congestion and nasal blockage, which is another form of hormonal rhinitis. And of course, other ladies might have some hypothyroidism. These hypothyroidism also might have hormonal form of rhinitis. But the main privilege of all these types of rhinitis, the hormonal rhinitis, is once you correct the hormonal imbalance, everything goes back to normal and you don't need any long-term medications. Okay, do we have any other non-allergic rhinitis variants? Yes, we do. Definitely speaking, we do have. We have gustatory rhinitis, which is present in everybody, of course, and that's the classic. If you're eating something spicy or something very hot, you will have some nasal discharge and nasal blockage. That's normal. That's called gustatory rhinitis. How about occupational rhinitis? We do have occupational rhinitis. Of course, if anybody goes into, let's say, a chemical factory, even if you don't have allergic rhinitis, you might have some occupational rhinitis from the chemicals and from the fumes that are inside any of these factories. And another issue is what we see in between brackets after bad nasal surgery. You might have atrophic rhinitis, and atrophic rhinitis is a little bit different than classical rhinitis, because here you will find that the discharge is not watery, it's going to be thick discharge and viscid discharge, and this is very important in managing it. If you give him something like an antihistamine, you'll make things worse because you're drying things more and more. So the line of treatment in atrophic rhinitis is quite different than in classical non-allergic rhinitis. How am I going to differentiate clinically between all these types of rhinitis? Okay, so if I want it new, I want some keys. How am I going to be? History. As I told you before, history. Number one, what was the key element? If you find itching, you are going to go to allergic rhinitis without any doubt. All right? And of course, if the patient tells you, when I'm exposed to a certain type of flowers, certain type of food, a certain type of dander, when I go inside a certain building, I start to get my symptoms, then this is an allergen exposure which the patient can identify. And this definitely helps us a lot in telling you that this is allergic rhinitis. And another thing, if it has a seasonal pattern, he tells you that in October, with the fall of leaves from the trees, I start to get some allergy, or I start to get some symptoms, and in between the seasons, I'm fine. Or when he tells you that when I start to use AC, the air conditioner with hot air, I start to get some allergy. This is another type of allergy. And of course, as I told you before, the intense itching. In non-allergic rhinitis, you have triggers. You say that I'm triggered by a certain perfume, I'm triggered by a certain smell, I'm triggered by a certain fume. In between, if I don't get exposed to this, I'm completely normal. Of course, if I'm going to have some medications, you ask the patient, are you taking antihypertensives? Are you taking hormonal therapy? Are you taking any vasodilators? All these things might tell you that this is a non-allergic rhinitis clue. And of course, you should ask, especially ladies, about if their hormonal balance is okay, or they're having replacement therapy for any hormonal disturbances. And as I told you before, you almost have no itching in non-allergic rhinitis. Okay, this is from the history of the patient. How about if I'm going to examine the patient? As I told you in the beginning, that in classic allergic rhinitis, you'll find pale, bluish, boggy, thickened mucous membrane, even in the septum itself, not only in the turbinates. And of course, you might have the patient have the shiners or a transverse nasal crease. You have nasal crease here. From what? From excessive sniffing. All patient is also sniffing and also blowing his nose, sniffing like that, and blowing his nose. And this leads to the shiners or the transverse nasal crease. But in non-allergic rhinitis, the mucosa looks of pinkish color. It might be a little bit congested, but it's pinkish. It's never bluish. It's never pale. It's always pinkish and almost sometimes red. Okay? And if you look at the septum, it's completely normal. And the secretions, they're not really watery. They're more a little bit, if it's going to be something, it's going to be a little bit thick, not watery, like in allergic rhinitis. So am I going to need any testing? Yes. How about what are you going to do? What are the tests you're going to do? First line testing is going to do a skin prick test if you're going to identify. Of course, this skin prick test is not present in every facility. So another thing you can do is a simple complete blood picture, and you'll find some eosinophilia. And if you find eosinophilia, start to look for immunoglobulin E. And if you find immunoglobulin E general, total immunoglobulin E high level, you might do a differential immunoglobulin E, especially if you're going to plan for immune therapy. Okay? If you're suspecting a little bit further advancement of this status, where you're going to find polyps or inflammatory response, you might need a CT scan or endoscopy to identify the extent of the disease and document the response to treatment. When you're going to give treatment and the patient is going to come for a follow-up, you want to document how much better he's going to be, and if this medication that you have prescribed is enough, or you're going to go a step up after that. So do we really need allergy testing? Yes, I do believe we do, because number one, you're going to avoid putting the patient in the wrong category. I mean, he might be allergic and you think he's not allergic, or he might be non-allergic and you think that he's allergic. So we must put him in the proper category. You might do this once in the very beginning of the diagnosis. You don't do it every time, but the patient, once you diagnose him, okay, he's going to be labeled as allergic rhinitis patients or non-allergic rhinitis patients, okay? What's the importance of putting the patient in the correct category? Number two is you're going to put him in the category for proper guideline management. As I told you before, if you're going to write an antihistamine in atrophic rhinitis or in a non-allergic rhinitis, that's not going to be of great benefit. You have to revert to local intranasal steroids or other lines of therapy other than oral antihistamines. So it's not something that you're going to take over the counter and got some running nose, please give me an antihistamine from the over-the-counter therapy. No, you have put him in the proper category. So you're going to tell him you're not going to work with oral antihistamines. You will have to work with local medication, whether it's steroid alone or steroid with other things. And number three, of course, it's going to guide me how to educate the patient. In non-allergic rhinitis, if it's something avoidable, like specific dusts or specific fumes or specific perfumes or specific food, okay, it's very easy. Please avoid 1, 2, 3, 4, 5. If it's an allergy, if it's an avoidable allergen, all right, you can avoid this avoidable allergen. If it's not, then you have to tell him that you have to control your exposure as much as possible. Like we put inside the house air purifiers, like we're going to change the pets, because some people insist on keeping their pets with them, and you have to do some anti-dandruff shampoos, and you have to put an air purifier beside him if he's really not willing to give up his pet. Is this going to implement and imply on our treatment line? Yes, definitely it can. As we see here, this is the prism of treatment. Of course, if we're in a perfect world, number one, I would do an immunotherapy by disease-modifying way. Of course, you're going to modify your allergic reaction, your immune reaction by desensitization. Of course, this is not very practical in everywhere. But the number two, and this is very important, is the intranasal corticosteroids, which can actually work in both types of rhinitis, whether it's allergic rhinitis or allergic rhinitis, with very minimal side effects, very safe, high safety profile, and they can be used, of course, on the on-label from the age of 6 and off-label from the age of 2. But I have to tell you that there is nothing called allergic rhinitis before the age of 3. So really, sometimes we have pediatricians telling us that, or referring us that a child with in the age of 1 or 1.5 years, and he's telling you that please treat this patient from allergic rhinitis. There is nothing called allergic rhinitis before the age of 3. You might have atopic dermatitis within a few months, let's say 9 or 10 months of age. You might have asthma, bronchial asthma, starting from the age of 2, but you almost never have nasal allergy before the age of 3. So is it safe to give nasal steroids from the age of 3? Yes, it's safe. As we said before, the newer drugs now are of minimal dose and minimal rate of absorption, and they don't have any effect on the hypothalamic pituitary axis, so they don't affect growth by any means. Of course, if one single therapy, as I stated before, which is the area guidelines, if one therapy is not enough, then you revert to a dual therapy, whether it's going to be adding antihistamines, oral or nasal. Of course, now we have nasal antihistamines in combination with the nasal steroid, which really gives a boost to the effect of the local treatment and a single therapy. All right, if this is not enough, then you might add adjuvant therapies like leukotriene modifiers and saline irrigation, and sometimes even short-term decongestants. For the saline irrigation, really the type of saline differs. You might have hypertonic saline or isotonic salines according to the type of allergy you have. If you want something to decongest, then you use the hypertonic type. If you want something to just clear away the pathways and remove the triggers that are precipitated on the nasal mucosa, whatever it is, whether it's inhaled fumes or dust or things like that, then we really should use the isotonic type. For the non-allergic rhinitis treatment, as we said before, still it's trigger avoidance, like eliminating the irritants, discontinuing medications, and environmental modification, and you might have to use intranasal therapy. What's the intranasal therapy that we use? Of course, we might have very good benefit from nasal corticosteroids, but not antihistamines. As I said before, antihistamines don't have any role in non-allergic rhinitis. But we have something else which is very beneficial, which acts as something that to dry the secretion, which is ipratropium bromide, and we have it in the form of a nasal spray. You can use the ipratropium bromide spray in conjunction with the steroid spray, or you can use it alone. It's very important to use it in old age, in senile rhinitis or vasomotor rhinitis of aging, and drug-induced rhinitis. It's also very beneficial to use ipratropium bromide. Senile nasal irrigation, as I stated before, you can use it safely for long-term use without any problems. Okay, and that's very beneficial, especially in non-allergic rhinitis. Is there current evidence-based therapy? Yes, intranasal steroids are effective for symptom control. Antihistamines, oral or systemic, it's only for allergic, not for non-allergic rhinitis. Allergen avoidance also when you have a triggering. Is there any triggering treatment line? Do you think there are any treatment lines? Yes. Of course, in addition to the subcutaneous or sublingual immune therapy, which shows promise, we have now immune modulators, what we call biological therapy, and we have IgE blocking substances. Okay, so you might use, especially if the patient has severe allergic rhinitis, and let's say that he developed nasal polyposis, and this nasal polyposis needed surgery once and twice, you might need either immunological therapy, which is the IgE blocking substances. I'm not going to talk about the medications now, it's not our topic, but we have IgE blocking substances, and we have the biological therapy, which is anti-interleukin 4 and anti-interleukin 13, which blocks the response completely. But of course, these are things that are of relative high cost than the classical therapy that we're talking about, and they are not for everybody. They are for severe cases or those that are not responding properly to the guidelines that we stated. Okay, so the cost of misdiagnosis, if it misdiagnoses that suboptimal rhinitis control, of course, in addition to depressing the patient that is not getting benefit from the treatment, and of course you're wasting everybody's time, you're wasting your time as a physician, you're wasting the time of the patient himself, he's losing his work hours, and of course you're costing the insurance company or costing the patient itself extra cost, and this is not something nice. So you must categorize it in the very beginning is which type of rhinitis. So the clinical takeaway today, the essential principles for rhinitis management. Number one, of course, you have to accurately diagnose him and put him in which category, all right, through thorough history, physical examination, allergy testing if needed, and of course, you specify the treatment accordingly, and you might have some personalized care like avoidance or adding some devices in the house like an air purifier or changing the floor of the house or changing the type of pet that the patient has if he's insisting on having pets. And thank you very much, and I hope you have benefited from this lecture as much as you can.
Thank you, Dr. Waleed, for your nice, informative presentation. And now we go to the second speaker, Dr. Faisal Abdullah Saadi, Associate Consultant Rhinology and Anterior Skull Base Department, King Abdullah Medical City, Mecca, and ENT Consultant at Abdurrasiya Group Health, Jeddah, presenting allergic rhinitis is not a minor disease.
For your introduction. Am I clear?
Yes.
All right. Thank you for the introduction, Prof. And I thank you, Bayer, for giving me this opportunity to teach our colleague and our younger colleague, those our target audience of my lecture. So to choose the talk, we are talking about one of the most common visited patient our clinics, those patients who's complaining of allergic rhinitis. And truly, it's not a minor disease. I'm seeing patients, how do they suffer? I'm hoping after at the end of this session today, all of us will be as a tool to help these patients. So the core concept is rethinking about allergic rhinitis. It's not a traditional nasal symptom or minor inconvenience or simple sneezing. No, it's an inflammatory cascade. It's a systemic disease that triggered by the nose, and it has a serious health implication. The recent evidence shows that over 400 million globally has allergic rhinitis, and 30% of them adults and 40% of them are pediatrics. Okay. Again, it's a cascade more than a runny nose. It's a nasal mucosa become buffed and the immune system start to activate. Then inflammatory cytokines start to recirculate in the bloodstream. Okay, the classic symptoms by sneezing, congestion, rhinorrhea, and itchiness and watery eye and nasal pruritus. The mechanism by symptoms that are driven by histamine and early phase mediators that be circulating the bloodstream. The burden how it starts by the circulating immune system, activating the T lymphocyte, then travel beyond the nasal mucosa. This will elevate biomarkers like interleukin-1, TNF, and IL-6, and this distal tissue affect by these mediators in the lungs, cardiovascular system, and the brain. What does it mean to be systemic inflammation? The immune system activate the T helper cell, and cell and monocyte become activated in the nasal tissue, then goes to the bloodstream and distal migration to the brain and other system. The immune cascade, it's understanding the complex of the immunological event that happen and driven by allergic rhinitis. It starts by minutes, the early phase, the mast cell, it starts to degrade, then the release of histamine and leukotrienes and the prostaglandin, then rapid symptom onset. After 4 to 8 hours, the T helper 2 cell recruit the eosinophil, basophil, and mast cell, and then start to sustain the inflammation. Then after that, it becomes chronic by keeping persistent cytokines circulating in the bloodstream. You see here the allergen, once exposed, trigger these cascade and start to be go on and off in the bloodstream and become chronic. How it's moved in the bloodstream? By adhesion molecules. Intracellular adhesion molecule 1 and vascular cell adhesion molecule 1. These two facilitate these all of this cascade to be traveled in the bloodstream. It's not released by itself. It's driven by histamine. So each one histamine reduce the systemic adhesion of these molecules to ICAM1 and decrease the eosinophil count. Because of that, you are giving antihistamine. Okay, I want to go further clinically, how these symptoms impact on the patient. This all theoretic part. Let us go further to clinical part. The allergic rhinitis impact sleep, cognition, mood, and further cardiovascular event. It's a hidden burden and affect daily function of the patient symptoms. By blocking the nose, then the patient start to have fragmented sleep, and as a result, he has a daytime somnolence like fatigue, reduced alertness, impaired his performance in work or school. We can see how it has triggered the nose, the neurological symptoms of the patient. Even the patient's not awake. I couldn't sleep. All patients come, doctor, last night I have very bad symptoms. I couldn't sleep. I couldn't go to work because of this. And this linked to cognitive impairment. It causes attention deficit, memory impairment, and reduced speed of making decision. The patient, imagine yourself, you are used to sleep at 8 hours, then the patient had fragmented sleep, patient cannot go for the deep sleep phase. These affect the cognition of the patient himself. Then the mood and productivity of the patient will be affected by increasing rate of anxiety, higher prevalence of depression, reduced emotional well-being, and social function impairment. And economic burden to reduce work productivity, and across multiple studies, this is proven and evidence-based. School performance in kids and absence of work, it will cost a lot. There is one invisible burden on daily life. It's the tired professional rub their nose, struggle through the meetings, they spread the infection. It's a common scene that we can see it all over. So another concept, which is the united airway concept, the allergic rhinitis and its link to asthma. It's a united airway. As we are seeing, it's the same mucosa lining the nose. It's the same lining the lung and the bronchotracheal tree. The upper and lower airway both linked together. Then if the nasal inflammation start, then the bronchial bronchoalveolar start to respond, then all of these be mediated by the systemic cascade. So we have direct and indirect pathway. The direct pathway, by patients start to have runny nose, post-nasal dripping, and cause all of these symptoms. But what actual cause is being triggered by the cascade. Both of them, the bronchial reflex, the vasoconstriction, the asthma, it starts all of these because of the triggers of these cytokines that circulating the bloodstream. So in this study, they have classified into minimum prevalence and maximum prevalence of 85% and 95%. You can imagine how much is caused by how much this be affected. Okay. All right. So regarding the treatment of the allergic rhinitis, evidence-based from the best way to approach this patient by giving intranasal corticosteroid and then giving the leukotriene receptor antagonist like montelukast in the patient with severe allergic rhinitis that with asthma, and allergic immunotherapy, sublingual immunotherapy, SLIT or SCIT. All of these help in reducing patient symptoms, and together with antihistamine. And please don't forget to give something local, decongestant. It will help the patient, but not more than 5 days. One another risk is the cardiovascular risk that links to allergic rhinitis. It's an emerging era that concern. It can cause a systemic inflammation and cardiovascular event by the chronic inflammation, persistent elevation of the inflammation, cytokines, then damage the blood vessel lining, and then can cause atherosclerotic disease. The adhesion molecules, the ICAM and VCAM, play a role in atherosclerotic plaque that develop. By how it's released, there's papers show that by persistent inflammation may exacerbate the hypertension and can increase the risk of coronary artery and potential risk of stroke by blocking the blood vessel, especially patients who had hyperlipidemic disease. And inflammation burden add to the cardiovascular system itself. This is the most important part of my lecture, how clinician and GP help these patients and how do they approach the patients. Please don't underestimate the allergic rhinitis. Okay, screen comprehensively. Ask the patients. You need to have screening tools in your clinic. I've seen one of the questions: how do I assess the patient? How to give him a proper treatment? I'm telling you, by asking him the proper question. Screen him very well. Ask the systemic symptoms. How does it affect his quality of sleep, the mood, and other comorbidities? Then assess the quality of life. Does it affect your work? Do you did not need to go to the work today because of the symptoms? And please don't forget other comorbidities like asthma, sinusitis, conjunctivitis, cardiovascular event, anosmia. For patient who has already nasal polyps or any other local disease in the nose. So how we do comprehensive management strategies by allergen avoidance and give pharmacotherapy and give immunotherapy. All of these help to control the patient symptoms. So the early and effective treatment to prevent by symptom control, improve sleep, reduce risk of asthma and other comorbidities, and decrease systemic inflammation. And then at the end, it will lower the cardiovascular event. From minor rhinitis to severe asthma, the initial presentation is the classic clinical picture. For example, a 35-year-old presented with allergic rhinitis for 5 years. Then disease progressed, developed worsening his asthma. Then complication happen like hypertension, systemic inflammation. Then it integrate by, we start the treatment by giving him antihistamine, nasal steroid, nasal decongestant, but not more than 5 days. And there is another new medications like combined therapy. You can give nasal steroid combined with nasal histamine. And all of these emerging medications, it's guide us to help the patient to control his symptoms. And then after that, the inflammatory markers, and other comorbidities like asthma start to be controlled. The systemic impact is up and down. And at each stage, the patient visits us and we can give treatment guided based on the patient's symptoms. It's also a really serious systemic disease. It's beyond nuisance. The inflammation itself condition, it's a far-reach health sequence. You have an important role to proactively treat these patients before you getting him out of the control limit. If the patient have allergic rhinitis, visit you in the clinic and continuously visiting you in your clinic and evaluating his symptoms, it's not progressing, not going further worse. This is the important rule that I want you all, my colleagues, to control. It's very important to intervene as much as you can earlier, so we can control the asthma, other comorbidities like cardiovascular events. Thank you all for attendance, and for any further question, we'll have it at the end. Thank you, Professor.
Professor, you're muted. Please just unmute.
Thank you very much, Dr. Faisal, for your nice presentation. And I'd like to welcome you to this panel discussion on allergic rhinitis, which is one of the most common chronic diseases affecting patients and quality of life, and often associated with asthma, sinus disease, and sleep disturbances. We are privileged to have an outstanding panel of experts with us today, and our goal is to discuss the practical, evidence-based approaches that can help us optimize the care for the best for the patient. So let's begin. First, with the first question, goes for Dr. Walid. What are the most common challenges in diagnosing allergic rhinitis in daily practice?
Okay, thank you. As I stated before, putting the patient in the proper category. I mean, you have lots of patients coming with a running nose or a blocked nose. And of course, we have some area classification into runners and blockers, but that really is not that important. What I really need to check is to put the patient in the right category. So, as I said in my very first presentation, please ask for the itching. If you really have an itching nose and an itching palate and an itching throat and an itching ear, it's very easy. Okay, thank you very much. I really don't need much more of your history. I don't need much more of your laboratory tests. You are an allergic patient. The issue is that sometimes you have some allergic patients without the classical itching form, and you might have him just having nasal congestion or running nose. That's the challenge. And that's when I start to look for some of the laboratory testing like an IgE level or a total eosinophilic level. The clinical picture, usually the patient comes having some of the medications taken already. So the classical bluish pale color of allergic rhinitis and the pinkish color of the non-allergic rhinitis is really not that clear in clinical practice. But please, again, put an emphasis on history taking and the itching issue, as I stated before.
Dr. Faisal, would you like to add anything?
No, thank you. Actually, I'm agreed with the prof that each patient should be treated and tailored based on his category that the prof talked about. Thank you, doctor.
Okay. The second question, what are the key updates from the latest allergic rhinitis and its impact on the area recommendations? Goes for Dr. Faisal.
Okay, thank you for the question. It's a patient-centered, control-based approach rather than focusing solely on symptom severity. So we assess both symptom burden and the disease control over time. The best way to give intranasal corticosteroid, and it's the most effective monotherapy to treat this patient. Then based on that, we can start like step ladder. We can start by nasal steroid. We can then give nasal steroid combined with nasal steroid with histamine, combination therapy. Then we can add oral antihistamine. And please, this is the treatment of the disease. We have additional symptom treatment, which is the nasal decongestant. We can add it. There is a lot of evidence proving that nasal decongestant with nasal steroid and antihistamine both effective in acute setting and later without the decongestant control of the disease. Okay, and also another like increased integration of the digital health tool to orient the patients by cleaning the carpets, the AC, and putting a mask when they have an areas that they are not cannot prevent themselves from the allergen. That's the area recommendation.
Yes.
Yeah,
Dr.
I'd like to add something. Yeah, I'd like that. Number one, for the decongestant, I accept that the patient has up to a month of oral decongestant if he's not hypertensive and doesn't have prostatic hypertension or something like that. But for the local decongestant, as everybody knows, not more than 5 days. For the step ladder issue that Dr. Faisal said, the area also now recommends that you can have on-demand therapy. I mean, you don't have to take your nasal steroid each and every day on a standard level. The area now states that you can use it until there is proper control of symptoms on a daily basis. And then after you control the symptoms, you can use it on-demand therapy. I mean, today the weather is not that good and I'm starting to have some congestion in my nose and starting to have some itching, then I can take the medication. If today the weather is fine and everything is fine, I don't have to take it on each and every day basis. That's the new recommendation. You don't have to use it on everyday basis now, especially if you have removed the triggers as much as you can.
Okay. Yes, thank you. I agree. Okay, and how should treatment be tailored according to symptom severity and disease control, Dr. Walid?
Okay, it's the same issue. I mean, number one, I always state that you use a single mode of therapy. I'm not saying I'm a single drug. And now we have a privilege of having a nasal local steroid antihistamine combination that's really excellent. And it saves you money and time and compliance. The second line after that is not oral antihistamines, actually speaking, it's antileukotrienes. In addition to the local nasal combined steroid and antihistamine. So the first line now is going to be the local nasal steroid antihistamine combination. If this is not enough, you're going to add antileukotriene. And I especially have a certain thought that you can add mast cell stabilizer as a third line. Even before adding oral antihistamine, you can use a mast cell stabilizer, especially in exacerbation of symptoms. And really it gets benefit, especially if it has ocular symptoms also, and it has excessive itching. It really mast cell stabilizers help a lot in that. So he's allowed to tailor his own, and I tell him, if you really have severe symptoms, you can take all 3 lines. If symptoms are less, you can use 2 of them, and if symptoms are under control, you can use nothing at all.
So you use the sodium chromoglycate just in the acute cases?
Yes, definitely.
Okay.
Yes.
So let's make it clear the audience. And when would you resort to the anti-leukotrienes?
Second line, in addition to the local antihistamine steroid combination.
According to the severity of the disease?
Yes, especially if it has associated asthma. I mean, it has a combined upper and lower airway. It's really greatly beneficial.
Yes. Okay, Dr. Faisal?
Yes. The same. Actually, the treatment can be tailored as Prof said, that we need to start from minimum to higher. The less medication we give, the higher compliance to the patient. We can start the ladder, as Prof said. Thank you. That's very important thing to orient our colleague about. Thank you, Prof.
Okay, thank you. And we go to some of the questions of the attendees. Dr. Omar Iswidi, which is your session today, and sees one rhinitis patient tomorrow. What's the single change you want them to make? Dr. Waleed?
Can you repeat the question, please?
If a GP watches your session today and sees one rhinitis patient tomorrow, what's the single change you want to make them? I guess he wants to make a single choice for the allergic rhinitis.
Simple local nasal steroid.
Yes,
okay?
I guess.
It works in all directions. It works in all directions. It doesn't contain the antihistamine that is not going to work for the non-allergic. Contains something that's going to work for both sides and it's going to be beneficial, let's say, in 70% of the cases. More than enough.
Okay, what are the second generation antihistamines still sufficient for many patients, or should intranasal corticosteroids be considered the first-line therapy?
Okay, this is a debate. All right, because actually speaking, what we have now called second are actually third generation antihistamines, okay? Because there was an era, let's say 20 years ago, we had second generation antihistamines, which were withdrawn for the market for plenty of the side effects and drug-drug interactions and drug-food interaction, if you recall them. So actually, what we have now, the loratadine and the Avastin and the ropatidine and things like that, they are third generation, but we'll call them second anyway. It's going to be fine if you have a nasal runner more than a blocker. For runners, it's not going to work that enough. You're really going to need a steroid if you have a runner. That's excessive secretions, all right? So that's why if you have a blocker, it's not going to be good. You have to use a combination. But if you have a runner, sometimes the oral antihistamine is going to be enough, but it's not going to be enough for a blocked nose. So I might revert them in a very mild case if the patient, especially if it has some bleeding from excessive use of the local nasal steroid. Some patients don't tolerate nasal steroids, and every now and then they have epistaxis. So, okay, I can turn them to oral antihistamines for a period of time with proper hydration of his nose to correct the damage that happened to the mucous membrane from the excessive use of the nasal steroid. By the way, the excessive use of nasal steroids is not the issue. It's the mode of application of the nasal steroid. People sometimes
the direction of the spray itself can cause like this.
Yes. So this is very important to teach the patient how to use this nasal steroid. And of course, if he has some sort of deviated septum, that might trigger the bleeding. And then I would revert to an oral antihistamine for a period of time, and then turn him back to a nasal steroid.
And also, we don't forget to assess the patient itself by doing scoping the nose, and there is some dryness. There is a lot of supportive medication like sesame oil would help to lubricate this scenario. And these patients, whether to give only nasal spray and they cannot outstand without it. So then additional medication like paraffins, like sesame oil spray, it will help in control of these symptoms of the patient.
Actually, I don't know what you have in UAE, but in Egypt now we have sprays that are fortified by panthenol cream. All right, so the panthenol itself is very soothing, and really helps in healing of injured mucous membrane. I don't know if you have them in UAE or no, but we have here nasal sprays that are fortified with panthenol. It's really nice.
There is the beauty of this medication. It's like treated as a herbal medication. It's over the counter. Patient can take it from websites at anywhere.
So you don't actually rely on dividing the patients according to the symptoms, or whether to tailor them according to the severity of the disease.
Prof, always divide the patient based on the symptoms: mild, moderate, severe. Each category of these patients you can treat accordingly. As Dr. Prof. Walid said, if the more mild with only nasal steroid, moderate with combined, severe combined with additional more treatment. That's the best way to approach the patient, by taking a very good history and doing proper physical examination, and then based on that we can treat the patient accordingly.
Okay.
Totally agree. Totally agree, of course. Of course, totally agree.
And then we go to another question. Which patients are ideal candidates for allergen immunotherapy? As Dr. Walid was discussing this.
Okay, so the patients, look, let's say in practical life practice, us as otolaryngologists rarely refer a patient for immune therapy, except if he has had extensive nasal polyposis with several surgeries and he cannot be controlled by medication. So that's when we revert to, let's say, immune therapy, or more now is biological therapy or injectable therapy. But of course, our colleagues in the chest department really refer much more patients, because having severe asthma that's not controlled by their medications is really more common than having a patient with the nights that's not responding. And I think that the patient suffers much more from bronchial asthma if it's in a bad condition than nasal allergy, because even if he has nasal polyposis that is obstructing his nose completely, what he can do is he's going to open his mouth. Okay, he's not going to have good sleep, he's not going to have good taste, but still he can live, let's say, semi-normal. But if you've got an asthma and he cannot move, he might die. So that's why the chest consultants really revert to immune therapy much more than we do. We refer them when we have had several surgeries for nasal polyps and the patient cannot be controlled and he cannot longer be performed surgery on. Then we refer to immune therapy, whether it's subcutaneous or sublingual or even the biological therapy, whatever it is. Yeah.
Biologic therapy. And how about you, Dr. Faisal? Dr. Faisal? Can you hear me?
I guess Dr. Faisal just is trying to fix the camera feed, so he's restarting. So he will join soon. You can continue on with the questions, Doctor.
Yes. And we have a question from the audience also. Allergic rhinitis often get misdiagnosed for years. What are the signs that child's frequent colds are actually rhinitis? Did I repeat this? Allergic rhinitis. Kids with allergic rhinitis often get misdiagnosed for years. What are the signs that the child's frequent colds are actually rhinitis? Dr. Walid?
Okay. Let's put several issues for pediatric allergic rhinitis. Number one, as I stated before, there is almost never allergic rhinitis before the age of 3. So if you have a child that's got running nose or blocked nose or excessive sneezing or excessive itching or whatever, please put in mind there is something before the age of 3. Please put in mind there is something else. And of course, the most common is adenoid hypertrophy. And you can really have adenoid hypertrophy starting from the age of 6 months, even 6 months. Okay? This is number one. Number two, you must put in mind that in children, such an early cause of allergy is usually related to indoor allergens, and really you have to look for pets, you have to look at the air conditioning, how it's going on, you have to look for the carpets, if it's moquette or something which is really thick and accumulates mold and algae and dust below it. And number 4, the feeding habits of this child. He might have allergy from excessive use of candies with artificial flavors and artificial colors. This is a very important issue to put in mind before saying that the patient is not responding to treatment. Of course, children have a point that you cannot really say he's taking the drug properly. Sometimes if it's a fluid, if it's a solution or a syrup, the child might spit part of it, might not swallow all of it. So it's a little bit different than in an adult when you're telling him you're going to take this tablet. Well and good. If it's not going to be good, you're going to use something else. In children, I think now we have something, chewable tablets for children that you can be sure that he's taking the whole dose, not if it's a syrup and he's spitting part of it, because sometimes children are under-treated. It's not poor control. He's not taking the proper dose from the medication you're prescribing for him. And also, lots of children refuse nasal sprays, and they really are a fuss for their parents to give them the nasal spray. So still, you're not delivering the medication properly. So whether you're writing an oral medication or you're writing a local nasal steroid or whatever you're going to write locally, please let the parent demonstrate in front of you how the medication is being administered to the child. This is very important. If all of this is a failure, I don't think we have approval worldwide for desensitization below the age of 6. I don't think we have any. Does anybody have any document then we can?
No,
right?
still not approved, Dr. Walid. And thank you for explaining that. Counseling the parent, it's very important how to use the medication. This is number 1. And then, as you mentioned, the adenoid is very important to rule out before this concept of frequent sneeze. It's not a frequent nose. It's not frequent nose. No, anything persistent, like patient visit you more than 2-3 visits, always look for think outside the box. It's not allergic rhinitis if not responding to proper medical treatment. Yes, Dr. Walid, thank you. Thank you for explaining that.
Thank you.
And here we get to the conclusion. As we conclude this seminar, I'd like to thank our distinguished panelists for their excellent presentations and to the audience for their participation and engagement. Today's discussion has highlighted the importance of accurate diagnosis and guideline-based treatment, patient education, and individualized care. We hope these insights will help improve outcomes of our patients with allergic rhinitis. Thank you all for joining us, and special thanks goes to Bayer and the organizing committee for their support and efforts in making this event successful. We look forward to welcoming you to future educational programs and have a wonderful evening. Thank you, everyone.
Thank you, everybody. Thank you, Dr. Faisal, Dr. Walid, and Dr. Hadi for this amazing session. I believe this was a very fantastic ending to our today's session, which was an incredible day. It has been fun from neurology to cardiovascular medicine to AI in clinical practice to rheumatology and ending by the allergy masterclass. Today's sessions were packed with cutting-edge insights delivered by some of the finest minds in medicine. Really a sincere thank you to all of our speakers, moderators, and participants for making Day 2 truly memorable. Your enthusiasm and engagement across the virtual platform made all the difference. We look forward to seeing you tomorrow for our final day. Take rest and see you tomorrow. Goodbye, everybody.
Goodbye. Thank you.
Thank you. Thank you. Bye.
Thank you.
Well, that's it.